Okay, so yesterday we have discussed about these rotator cuff muscles. Okay, these are set of four muscles which are supraspinatus, infraspinatus, teres minor, and the subscapularis. We have discussed the nerve supply of these muscles. We have discussed what muscles are involved in the abduction of your hand from 0 up to the more than 100-degree this angle, right? We have discussed about the supraspinatus muscle, which is the most common muscle that get injured in any kind of injury to the rotator cuff. Okay, and we have discussed about this empty can test. Then we've discussed about the brachial plexus and how it supplies all these muscles of your arm, hand, forearm, right? All these structures, and what gonna happen if any nerve which originating from this brachial plexus get damaged at different locations, right? And you should be able to know by looking at the symptoms of the patient that at what location the nerve must be damaging, what nerve would be damaging at what location. You should be able to identify by looking at the symptoms of the patient, right? So for that you need to remember that axillary nerve is at the most proximal is supplying the most proximal structures. Then comes the musculoskeletal only for the arm. Then the radial nerve supplying all the way from the shoulder to the hand, all the posterior structures, right? Then the median nerve again from arm to hand, supplying the anterior structures. Then you have the ulnar nerve, which is supplying most distal structures of your forearm and the hand, right? We have discussed about the palsies involving the brachial plexus, the Erb's palsy, right? The Klumpke's palsy, thoracic outlet syndrome, and the winging of the scapula. We have discussed the cause of it. Then we have discussed the features you get in these palsies, right? And what deficits would be present. We have discussed all these matters. We've discussed about the wrist region, right? What bones are present in the wrist and what bones when damaged or when dislocated, what syndromes can occur. For example, we have discussed about this hamate bone that can cause the Guyon's canal syndrome, and then the lunate bone dislocation, which can cause a carpal tunnel syndrome. We have discussed about this scaphoid bone, which is the most common bone would be fractured in any kind of injury to the wrist. And whenever it gets fractured, it will always lead to the avascular necrosis of the proximal segment, right? Because of the retrograde blood supply. We have discussed what that means, right? We've discussed about the humeral neck fracture, in which you have these two arteries, which are the anterior and the posterior circumflex artery. They will get damaged, and as a result, the supply to the head of the humerus will be lost. And what patient get it? He will get the avascular necrosis of the head. Okay, the flattening of the head will be seen on the X-ray, right? The pain will be there, a very severe shoulder pain will be there. The range of motion will be decreased. So these are all the symptoms of the humeral neck fracture. We have discussed about the hand muscles, and these are the thenar, hypothenar, interossei, and the lumbricals. Four group of muscles. For the thenar, you will be having this opponents, okay, the abductor and the flexor pollicis. Okay, you can remember them by the name OAF. Okay, that is opponents, abductor, and the flexor. Similar goes for the hypothenar, opponents, abductor, and the flexor, but it is a digit minimum. In case of thenar, it will be the pollicis. Okay, and then the dorsal interossei muscle and the palmar interossei muscle. DAB, that means the dorsal abducts, and the palmar, they adduct, right? Then you have the lumbricals. Okay, function of lumbricals is to cause the flexion at the metacarpopharyngeal joint and to cause the extension at the PIP and DIP, right? We have discussed about these muscles in the forearm that can cause the extension or the flexion in my hand, and these are the digitorum muscles that supplying the digits, right? And for the phalanxes, you have for the flexion, you will be having this flexum digitorum superficialis for the proximal interphalangeal joint, flexor digitorum this profundus for the distal interphalangeal joint. For the extension at the fingers, you have the extensor digitorum, okay, that for the PIP and DIP, and the extensor digiti minimi for the little finger, right, for the fifth one. For the wrist extension and flexion, you will be having this carpi muscles, right? The extensor carpi radialis and the extensor carpi ulnaris. Similarly, extensor carpi flexor carpi radialis and the flexor carpi ulnaris. We have discussed about these muscles. Okay, we have discussed what gonna happen if you get that the damage of a nerve, which is what gonna happen if the damage is proximal, and what gonna happen if the damage is distal. We have discussed all these four scenarios. Then we have discussed about the your lower limbs, the muscle in the anterior compartment and the muscle in the posterior compartment. In the anterior hip, all the muscles they will cause the flexion. For the posterior hip, all the muscles will cause the extension at the hip. Okay, and these muscles either can cause a lateral rotation or they can cause the medial rotation, right? For the posterior hip muscles, they will be causing the extension at the hip as well as mostly the lateral rotation, but the gluteus medius and minimus can cause the medial rotation. Similarly, for the anterior hip, you will be having the muscles which can cause a flexion at the hip as well as the internal rotation, but some of the muscles can also cause the lateral rotation like iliopsoas muscle that causes the lateral rotation. Okay. We have discussed about this action of the muscles, right? At the psoas axis. And from today, we will start this lumbar plexus. Similar to the brachial plexus, which is supplying the structures or the muscles of your upper limb for the movement, you have the lumbar plexus, which is supplying the lower limb for the movement, right? And the nerves which are originating from this lumbar plexus includes the iliohypogastric nerve first, and it supplies the proximal structures, of course, just like my brachial plexus. It originate from the T12 to L1 roots, okay, and it supplies the suprapubic region for the sensory one, and the this transversus abdominis and the internal oblique muscle in the abdomen, okay. So the internal oblique muscles and the transverse abdominis muscles, it is supplied by the iliohypogastric nerve. Do remember this name, and the suprapubic region, it is also supplied by the iliohypogastric nerve. So whenever you have a burning sensations in the suprapubic region, in case of UTI or in case of any cesarean section, after cesarean section, you will have this burning sensation sometimes because of damage of this nerve, right? So whenever you have a suprapubic tenderness, whenever you have a suprapubic burning pain, right, in case of UTI, okay, it is all because of this iliohypogastric nerve. Okay, very important. Then you also have the ilioinguinal nerve. Along with the iliohypogastric nerve, you also have this ilioinguinal nerve that also supply the transversus abdominis and the internal oblique. Okay, so both the ilioinguinal nerve as well as the iliohypogastric nerve, it supplies these muscles together, right? Then you have the genitofemoral nerve. As the name suggests, it's supplying the genitals as well as the femoral region. Okay, for the sensory supply, it supplies the scrotum or the labia majora. Okay, and of course the medial thigh, just above the this is a location for the obturator muscle. Okay, above the obturator muscle, you will be having the genitofemoral nerve region, right? And for the motor, it will be supplying the cremastric muscles or the cremaster muscles. And if you guys remember, you have the external spermatic fascia, then the cremaster muscles, and then the internal spermatic fascia, right? And these cremastric muscles, they can cause the contraction in my scrotum, right? So whenever you stimulate this this nerve in the medial thigh, okay, this can cause the cremastic reflex, because this nerve also supplies the cremaster muscles, right? So that's why this nerve is involved in the cremastic reflex. For that, you need to stimulate the nerve in the medial thigh, okay, by stimulating the middle of the thigh, right? And you need to know the location of the middle thigh. That means a lateral to the femoral triangle. See, you have the femoral triangle, right? And lateral to the femoral triangle, it is supplied by the genitofemoral nerve. Okay, it's still the medial thigh, but kind of lateral to your this femoral triangle, right? And the ilioinguinal nerve, it supplies in the medial of this uh, the femoral triangle. If I try to annotate it, just give me a second. You have this thigh, okay, and you have this medial part of the thigh, right? This is the middle part of the thigh. In the middle part, you also have this this canal and that triangle, the femoral triangle. Okay, medial to the femoral triangle, you have this ilio-inguinal nerve supplying this region, and lateral to this part of the triangle, the femoral triangle, you have the genitofemoral supplying this region. Below the genitofemoral nerve and this ilio-inguinal nerve, you have the obturator nerve supplying this region. Okay, so all these nerves, these are supplying the sensory innervations from these are uh, the sensory innervations from the middle of the thigh, right? But this obturator nerve, it supplies below this the femoral triangle, okay, while the genitofemoral nerve and the ilioinguinal nerve, it supplies the uh, lateral and the medial part of this uh, femoral triangle. Is that okay?
Yes.
So, yeah. So do remember this: the lateral part to the femoral triangle supplies by the genitofemoral nerve, and the medial part of this femoral triangle is supplied by the ilioinguinal nerve. And the ilioinguinal nerve, it also supplies the transversus abdominis and the internal oblique, right? So whenever any kind of damage happens, okay, like in case of any laparoscopic laparoscopic surgery, okay, you can have a decreased sensations in the medial of the thigh, okay, as well as in the anterior thigh, right? And you will have the absence of the cremastic reflex. Very important to know, right? Then you have the lateral femoral cutaneous nerve. As the name suggests, it is just a cutaneous nerve, which means a sensory nerve, no motor function, and it supplies the lateral part of your thigh. Okay, it supplies the lateral and the anterior part of the thigh. Okay, and it is just a purely sensory nerve. It has no motor function, right? It mostly kind of impinge in the at the this at the inguinal canal. Okay, and the risk factors includes a tight clothing, which means it can be it could be a belt, a very tight belt. It could be due to obesity, it could be due to pregnancy, and it could be due to the pelvic procedures. Okay, and this nerve will be compressed at the inguinal ligament because of that. And whenever the nerve gets compressed at the inguinal ligament, you can have a burning pain in the lateral of the thigh, okay, as well as a decreased sensations in the anterior and lateral thigh. Okay, the neuropathic pain will be there, which means a burning pain will be there in the lateral location. Okay, so it could be a patient who is having a history of this obesity and he's traveling to some location with these belts and all these things on, and suddenly in the trip he started having this the lateral pain in the thigh, right? The lateral burning pain in the thigh, and that's how you know that the patient is having a impingement of this nerve. Okay, and only sensory functions will be affected, no motor loss. This is very important to note. It is a purely sensory nerve. Okay, then you have the obturator nerve, okay, which supplies a sensory innervation to the medial thigh, okay, and well as a motor innervation to the obturator muscles, of course the obturator externus, and all the adductor muscles, the adductor longus, adductor brevis, adductor magnus. Okay, so you can say that this nerve is mainly involved in the adduction of the thigh. Whenever you stimulate this nerve, you will have the adduction of the thigh, right? Because it's applying the adductor muscles as well as the obturator externus. Okay. And do note that it is the obturator externus, not the obturator internus. Okay. This is also very important to note. Just give me a second. Yeah. So it is the obturator uh, externus, not the obturator internus. It is very important to note, right? And if you get a damage of this nerve, like in some kind of a pelvic surgery, any kind of pelvic surgery, right? So in that case, you can have a damage of this nerve, and when a damage occurs, it leads to a decrease in the sensations of the thigh at the medial side, as well as you will have a loss of adduction. Okay, because this nerve is mainly helping the adduction of your uh, thigh or your leg, right? This is very important to note. And Then you have the femoral nerve, okay, which is originating from the L2 to L4 again, okay. It supplies your anterior thigh, okay, lateral thigh for the lateral femoral cutaneous nerve, anterior thigh for the femoral nerve, right, as well as the medial side of the leg, okay. So you have the anterior thigh and the medial of the leg. The medial side of the leg is supplied by another branch of this femoral nerve, which is known as the saphenous nerve. You have the saphenous nerve in the body, which is a branch of this femoral nerve, and it supplies the medial side of the leg. For the motor, for the motor innervations, you have the quadriceps, iliacus, pectineus, and the sartorius. Okay, the quadriceps includes the rectus femoris muscles, as well as the vastus lateralis and the vastus medialis. All of these muscles are involved in the hip flexion and the knee extension. Okay, so if you want to say the symptom, if you want to summarize all this function of this nerve, you can say that this nerve is involved in the flexion of the hip as well as the extension at the knee. So whenever you get a damage of this nerve, you will always have a loss of flexion at the hip and the extension of the knee, because all of these muscles this nerve is supplying, they all are involved in these actions. Any kind of pelvic fracture can lead to the damage to this nerve. Okay, and sometimes any hematoma which is involving the psoas muscle, right? Any kind of abscess, like in case of a sob abscess, you can have an irritation of this nerve also, right? In that case, we'll having the decrease decreased sensations in the leg will be there. You will be having a loss of this flexion of the hip, and you will be having a loss of extension of the knee also because of damage of this femoral nerve. So note this, very important. Then you have the sciatic nerve from L4 to S3. Okay. It supplies mainly the motor innervation to the semitendinous, semimembranous, biceps femoris, and the adductor magnus. And all of these muscles are present in the posterior compartment of your thigh. Okay. And these muscles are involved in the hip extension and the knee flexion. So whenever I get the stimulation of this sciatic nerve, I can have a hip extension and the knee flexion, right? And this nerve passes very closely to your hip joint, right? So whenever a posterior hip dislocation occur, right, in which the symptoms will be like the hip will be flexed and will be internally rotated, and your thigh, the affected thigh, will be very shortened and the adducted. So that's how the step one will describe your case of posterior hip dislocation. They will tell you that the hip is kind of internally rotated, okay, and shortened and adducted, okay, your thigh. So that's how you know that the patient is having a posterior hip dislocation. In that case, the sciatic nerve will be the first nerve to damage, right? Herniation of the disc can happen, the radiculopathy. In that case, also the sciatic nerve can get damaged. Quina syndrome, right? In that case, also you can have a sciatic nerve damage, okay? And then you get a loss of hip extension and the knee flexion. Finally, after entering the leg, this nerve will be divided into two parts. One is the tibial nerve and second is the fibular nerve. Okay, so tibial nerve and the fibular nerve are the branches of the sciatic nerve in the leg. Is that okay up to here?
Yeah.
Then if you look for the blood supply of the femoral head, then you have first the deep arteries of the thigh, right? And from these deep arteries, you have two nerves. You have two arteries. Okay, the lateral circumflex femoral artery and the medial circumflex femoral artery. Okay, this is a lateral circumflex. This is a medial circumflex. The medial circumflex femoral artery takes the major part. Okay, it supplies a major part of the head of the femur, while the lateral artery supplies a minor part of the head of the femur. It divided into the ascending branch, transverse branch, and the descending branch then. Okay, so whenever you have any kind of a damage involving this medial circumflex femoral artery, you can have a avascular necrosis of this femoral head. Is that okay?
Yeah.
Okay. And if the step one asks you that what muscles are involved, when you ask the patient to sit up from the supine position, you have a patient who is slowing down supine, and you ask them to raise and sit up, right? So, the major muscles, the iliopsoas muscle is the most important one. Okay, the iliopsoas muscle will be the most important one. And second, the hip flexors are also important. So if the step one asks you what is the most important muscles, okay, in raising from a supine to a setup position, this will be the iliopsoas muscles and the hip flexors, mainly the iliopsoas muscles. Okay, and you have this one syndrome known as the piriformis syndrome. Okay, because you have the sciatic foramen. Okay, and the major part of the sciatic foramen is kind of occupied by the piriformis muscle. Okay, first of all, you have the sciatic foramen, and it is divided into the two parts, the lesser part and the greater part. It is by the sacrospinous ligament. Okay, and the greater part of the sciatic foramen is mostly occupied by the piriformis muscle. So in a scenario, if you're having some kind of a the inflammation of this muscle, of the piriformis muscle, or any kind of edema of this piriformis muscle, in that case, because the sciatic nerve passes very in close association with this nerve, with this muscle. Okay, so in that case, the nerve can get discompressed, right? And as a result, the patient can have a loss of functions of the sciatic nerve. So this is known as a piriformis syndrome. So Stephen will ask you, you will encounter a patient who is having an inflammation to the piriformis this muscle, or the edema of this muscle, or the hypertrophy of this muscle, and they will ask you what is the most common presenting complaint of the patient. That means what they were asking about the deficits of the sciatic nerve, right? They want you to know that the sciatic nerve lies in very close association with this piriformis muscle. Whenever an inflammation, edema occur or hypertrophy occur, that can lead to the compression of the sciatic nerve. Sciatic nerve can be damaged into the herniated disc, which means the radiculopathy. Could be due to the posterior hip dislocation, could be due to the discordant corner syndrome, or could be due to the piriformis syndrome. Is that okay?
Yes.
Any doubt on this page?
The one which you said, which artery was causing avascular necrosis of the femur?
Medial
The
circumflex.
Okay, and not the lateral.
No, not the lateral. Lateral can cause it, but the most of the structures are supplying by this artery, the
Yeah, yeah.
male circumflex artery. So this is the most common one involved.
Okay, okay, got it. Thank you.
Any more doubt? Okay. So that was about my thigh. Okay, all the nerves which are originating from my lumbar plexus. Okay, how they're supplying my thigh, right? And now comes the leg. Okay, first we have the femoral nerve and the tibial nerve, and these are the branches of your femoral. These are the branches of your sciatic nerve in the leg. Okay, you call it a common fibular nerve, also known as the common peroneal nerve. Okay, and this nerve when enters into the leg, it will be divided into the again two nerves. Okay, the superficial and the deep part, the superficial fibular or the superficial peroneal nerve, and the deep fibular or the deep peroneal nerve. Okay, the superficial nerve supplies the dorsum of your foot, very important, except the web space between the helix and the second digit. You have the helix, you have the second digit, the web space in between these two parts, it is supplied by the deep fibular nerve. Okay, while the superficial fibular nerve, it supplies all the way, the dorsum of your foot, as you can see here. Okay, the motor supply is supplied by the motor supply is to the peroneus longus and the peroneus brevis, and these muscles are involved in the eversion of the foot. Okay, so you can forget the name of these muscles, but you just remember the function of this nerve. Okay, the motor function is to cause the eversion of the foot. Very important. Okay, so the sensory innervation in the lateral side of the leg, the dorsum of the foot. Okay, and the eversion of the foot is done by the superficial peroneal nerve. Then you have the deep peroneal or the deep fibular nerve supplying the sensory innervation to the web space between the helix and the second digit. Okay, as well as the motor innervation that is causing the dorsiflexion of the foot. This is the dorsal part of the foot. You will when it get flexed this way, you will call it a dorsiflexion. Okay, it is done by the this nerve, the defibular nerve. Okay, then the extension of the digit. and the inversion of the foot. Okay, inversion of the foot, extension of the digit, and the dorsiflexion of the foot. It is done by the deep fibular nerve. Okay, you have these two syndromes known as the lateral compartment syndrome and the anterior compartment syndrome. In case of the lateral compartment syndrome, this nerve, the superficial peroneal nerve, will get damaged, and as a result, you will get a loss of sensations from the lateral side of the leg, okay, from the dorsum of the foot, and as well as you also have a loss of eversion of the foot. Okay, this will be the symptoms whenever you have a lateral compartment syndrome. We will discuss that later, what the syndrome is actually, okay, in the pathology section. Then you have the anterior compartment syndrome, okay, in which the deep fibular nerve will get damaged, and as a result, the patient will get a loss of dorsiflexion, okay, and this will appear as a dropping of the foot, loss of extension of the digit will be there, right, and as well as a loss of inversion of the foot will be there, okay, but the eversion is normal, and the senses is absolutely normal. Only the sensory loss in the web space of the hallux will be there, right? So yeah, that will be the foot drop. Whenever you have a damage to this deep peroneal nerve, you will have a foot drop. In case if you're having a damage to this common fibular nerve, okay, which generally happens at your knee part, right, in the lateral part, which is your the fib, uh, the fibular bone, okay, the fibula, okay. At the fibula, this nerve, the common fibular nerve, can get damaged, and in that case, you will have a loss of sensory innervation in the lateral leg, dorsum of the foot. You will have a foot drop. You will have a loss of extension of the digits. You will have a loss of this eversion as well as the inversion, right? So yeah, that would be all about the common fibular nerve. So damage can happen because of the compression of the leg in the lateral aspect, as you can see in this diagram. This is your femur. This is a fibula. This is a tibia. Okay, this is a sciatic nerve. Okay, which is running uh, posterior to my femur. Right, it will enter into the junction of the thigh and the leg. From there, it will come anteriorly. Okay, in a very close association with the fibula. Right. So whenever you have any kind of fracture involving the head of fibula, right, in that case you can have a damage to the common fibular nerve, okay, and then you can have this all these symptoms. Is that okay?
Yes.
So that was all about the common fibular nerve, right? Then you have the tibial nerve, which is again a branch of my sciatic nerve, okay, in run posteriorly. It supplies the sensory innervation to the sole of my foot, okay. For the motor, you can remember the plantar flexion, okay, the flexion of my digits. The extension of the digits is done by the defibular nerve. The flexion of the digits is done by the tibial nerve. The dorsiflexion is done by the defibular nerve. The plantar flexion is done by the tibial nerve, right? As well as in some way, the most of the time, you can say the major part of the inner this inversion of the foot is done by the tibial nerve. Although both the deep fibular nerve as well as the tibial nerve, they both are involved in the inversion of the foot, but majorly the tibial nerve is involved in the inversion of the foot. Okay, so these are all the functions of the tibial nerve. The sensory one includes the supplying the sole of the foot, and the motor one includes the inversion of the foot, the plantar flexion as well as the flexion of the digits, right? How you can damage the tibial nerve? Because it runs posterior compartment. Okay, so whenever you have any kind of knee trauma in which your the tibia can get a posterior dislocation. Whenever you have a posterior dislocation of the tibia, okay, this nerve can get damaged. Okay, if you have a Baker cyst, which is seen in case of rheumatoid arthritis, right, you can have the tibial nerve damage. In case of tarsal tunnel syndrome, which is a very most distal lesion, here it will happen the tarsal tunnel syndrome, okay, through which this nerve will enters your foot from the leg, right? There it can get damaged. You will have the deficits for the tibial nerve, okay, and only the sensory loss will happen, okay, because all of the muscles to the all the branches to the muscles are already given. So whenever you have a tarsal tunnel syndrome, it is only the sensory loss happen. right? And you guys remember about the antecubital fossa in the hand, in the upper limb?
Yeah.
Similarly, you have this popliteal fossa in the leg also, right? Just behind my knee, you have this popliteal fossa, right? And mostly in case of popliteal fossa damage, you will have a damage to a tibial nerve. Okay, and this nerve just lie exactly posterior, immediately posterior to my tibia, right? So any kind of damage to the popliteal fossa, any kind of a puncture wound, you can say, any kind of posterior dislocation of the tibia, right? And any kind of a trauma to the knee or a Baker's cyst, which is present in the popliteal fossa again, you can have a damage to a tibial nerve. Okay, and whenever a damage occurs, the patient cannot get a plantar flexion, and that means he cannot stand on its toes. Very important. The patient cannot stand on the tiptoes. While in case of a deep fibular nerve damage, the patient cannot do the heel walking. Okay, because the causes are dorsiflexion, so patient can able to walk on the heel. But if the nerve can get damaged, the dorsiflexion is lost and the patient cannot walk on the heel. In case of tibial nerve, the patient cannot walk on the tiptoes. Right? You will be having a loss of sensations from the sole of the foot. Okay, and the patient can also have the version of the foot, okay, because of loss of innervation for the inversion. Okay, the superficial fibular nerve will get will overcome this nerve, and as a result the patient will get the E version of the foot at the rest. Very important. Because of loss of inversion, because of loss of this nerve, you will have the E version of the foot at the rest, as well as a loss of inversion, and the plantar flexion will be there. Achilles tendon reflex will also be absent in that case, right? And yeah, that would be all about it. Any doubt on the tibial nerve?
No, thank you.
Okay, then you have the superior gluteal nerve. Okay, and the superior gluteal nerve is supplying your gluteus medius and gluteus minimus mainly, as well as the tensor facial artery. Okay, so gluteus medius and this minimus mainly supplying by the superior gluteal nerve. Okay, the function of these muscles you guys already know. They help in the hip balancing, right? The balancing of the pelvis is done by these muscles. Apart from that, these muscles are also involved in the hip abduction. You guys know that. And the internal rotation mainly. Okay, and internal rotation happens whenever my whenever my hip is flexed, and the external rotation happens whenever my hip is extended. Okay, so in a standing position, I will be having a external rotation because of these muscles, and whenever I'm sitting, I will be having a internal rotation, right? uh, Due to these muscles. Okay, so the damage of this nerve can happen whenever you choose the superior medial quadrant for the injection, for the IM or the IV injection. Okay, will the IM one. Okay, so whenever you give the patient this IM injection or the intramuscular injection in the superior medial region, if you can divide this into 4 parts, you will get a superior medial location, which is a location of this nerve, the superior gluteal nerve. It can get damaged there. Okay, so you need to prevent this condition by choosing the superior lateral quadrant. Okay, very important. So the cause of injury is mostly the iatrogenic only. Okay, during giving the patient intramuscular injection, if you give the injection somehow in the superior middle this quadrant, then you can have a damage of this nerve. And when the nerve can get damaged, you will have a Tendenberg sign, okay, in which the pelvic tilts because of the weight bearing leg cannot maintain the alignment. So what happens is ultimately the function of these muscles is to cause a downward movement of this pelvis, right? So whenever the lesion of this nerve occur, okay, and the function of these muscles are lost, now the pelvis cannot be tilted downwards at the at a damaged area, right? So what happens? The pelvis will be tilted upwards. This side is normal, which is downward, and the upward part, okay, the side where the pelvis is tilted upwards, okay, you will be having a lesion there. Okay, so so the lesion is always contralateral to the side of the hip that drops. Okay, and ipsilateral to the extremity on which the patient stands. So that's about the superior gluteal nerve damage. So please remember other functions of these muscles also. Apart from maintaining or stabilizing your hip, they also involve in the hip abduction. They also involve in the external rotation whenever I'm standing, and the internal rotation whenever I am sitting or I'm flexed. Right? If the damage occurs, you will have the Trendelenburg sign, in which you have the the upward tilting of this pelvis at the affected side, and the lower tilting or the depression of this pelvis in the contralateral side. Is that okay?
Yeah.
Then you have the inferior gluteal nerve, which supplies your gluteus maximus. Okay, and the gluteus maximus is involved in the hip extension as well as the abduction, right, and the external rotation or the lateral rotation, right? And yeah, this nerve can be get damaged in case of a posterior hip dislocation, right? And whenever the nerve can get damaged, you won't have this extension at the hip. Okay, so the patient will be having a difficulty climbing the stairs. Patient will be having a difficulty raising from the chair. Okay, and yeah, you will also have a loss of hip extension because, right? So any doubt on the inferior gluteal nerve?
No, thank you.
Finally, you have the pudendal nerve supplying by the S2, S3, and the S4 nerve roots. Very important to note the nerve roots, right? For a sensory, it is supplying your perineum. Okay. For the motor, it will supplying the external urethral and the anal sphincters, and these sphincters are in our voluntarily controlled, right? And the nerve damage can occur during a stretch injury during the childbirth. Okay, for the prolonged cycling and the horseback riding, you can have a damage of the pudendal nerve. In that case, the sensory loss over the perineum will be lost. The sensory innervation, sorry, the sensory innervations from the perineum will be lost. Okay, and also in the genital areas. And because the sphincter tone is now lost uh, because of the loss of this nerve, okay, what you can get is the fecal incontinence or the urinary incontinence. Because of loss of the sphincter function, you will be having a fecal incontinence or the urinary incontinence. And sometimes you have to kind of block this nerve by giving the anesthesia, and this is done during the child delivery. Okay, and to avoid the pain, of course, right? So this nerve can be blocked with a local anesthetic during the childbirth. Okay, and you need to identify the landmark, which is the ischial spine, and this procedure is known as the pudendal nerve block. So the pudendal nerve block is basically done at the time of delivery for a childbirth to avoid the pain, right? And for that, you need to identify first the ischial spine tip. Okay, and then the ischial spine, you will block the nerve with the help of the local anesthetic. Okay, very important. So yeah, that would be all about this nerve. Any damage? Oh, sorry. Any doubt?
No, thank you.
Sir, did you go
Yeah.
over the inner wing reflex?
Oh, the anal wing reflex. See, because this nerve is supplying all the sensory innervations to the perineum as well as the muscles or the smooth muscles of the external urethral and the anal sphincter. So whenever I want to do the anal wing reflexes, okay, it is all because of the pudendal nerve, right? Whenever I uh, uh, whenever I kind of stimulate the skin over the perineum, right? You will get the contraction at the anal region, right? Because of this external anal sphincter, right?
Mhm.
And this is known as the anal wing reflex. So it will get also damaged. This reflex will be absent whenever I block this nerve or whenever I get the damage of this nerve. Like in case of a saddle anesthesia, right? The Kodak corner syndrome. In that case, I can get the loss of anal wing reflex also because of loss of the pudendal nerve.
All right, thank you.
And just give me a second. Let me check if I'm not missing anything. Yeah, and the easy way to remember that uh, what nerves are supplying in what region. Okay, and these L2, L4, these nerve roots, you need to remember this diagram. What to draw? If this is your thigh, let's say, right? This is your knee. This is your leg. Okay, and this is your foot, right? So, say this point is L4. Okay, this area is L4. Okay, so above L4, okay, every nerve who is having the L2, L3, L1, they will all supplies only the thigh structures, and only the nerves which are having these nerve roots after the L4, like the L5, okay, and and the S1, S2, and S3, they will be supplying the structures of the leg. Okay, so above L4, it will be your thigh, and below L4, it will be your leg. Okay, so for every nerve, you can see here, every nerve which is having a nerve root above the L4, they will be supplying only the thighs. Okay, and the nerves which are having these nerve roots after the L4 will be supplying your leg. Okay, is that okay for now? Is that okay up to here?
Yeah, but the femoral nerve is having L2 to L4 and it is still supplying a part of the leg.
We will discuss that, don't worry. We will come to that again. Don't worry about that. Okay. Yeah. So just for now, L4 is at this knee location, right? Above the L4, you'll be having a thigh. Below the L4, you'll be having the leg. Okay. And I can write it down like as 4, 3, 3, 2, and 4, 5. These are the nerve roots. Okay. And this is where your actual thigh started. Okay. This is the inguinal ligament. Okay. So as you can see at the hip, okay, whenever I want to do the flexion or the extension of the hip, I want to stimulate the nerve roots which are L3 and the L2. Okay, so 2, 3, L2 and L3 will be supplying at the hip, okay, for the flexion. Okay, then you have the L4 and the L3 supplying your knee, okay, for the knee extension, right? And then you have the L4 and the L5 supplying your foot, okay, for the dorsiflexion. Is that okay?
Yeah.
So whenever I stimulate the nerve roots L4 and L5, the step one asks you what nerve roots are involved in the dorsiflexion of the foot. You can easily say that it is the L4 and the L5. You just need to remember this sequence 2, 3, 3, 4, and 4, 5. Right? Whenever the step one asks you what nerve roots are involved in case of the knee extension, these are the L3 and L4. And what nerve roots are involved in the hip flexion, these are the L2 and L3. So in case of radiculopathy, because in case of radiculopathy, I will be compressing the nerve roots, right? In that case, if I compress the nerve roots L4 to L5 because of any this disc herniation or something like that, if I compress my nerve roots from L4 to L5, then in that case, I will be having a loss of dorsiflexion. Is that okay?
Yeah.
So that's why you need to remember this part, the diagram, okay? That the L4, L5, they will be supplying the this foot part, okay, for the dorsiflexion. Okay, this L4 and L3 supplying the knee for the knee extension, and the L2 and L3 supplying the hip for the hip flexion. It will help us when we study radiculopathy. Okay, the symptoms of the radiculopathy, it will make it very much easy to remember, right? And for the sensory, you need to remember the dermatomes. Okay, we will discuss dermatomes later. For the sensory innervations, you need to remember the dermatomes, what dermatomes are supplying what regions. Okay, and it's all about the dermatomes which are supplying there, right? So we will discuss that later for the sensory innervations. Just for the motor, you just remember this part, that the L2, L3, whenever I stimulate the nerve roots from the L2, L3, I will have the this flexion of the hip. For the L3, L4, I will be having the extension of the knee. And for the L4 and L5, I will be having a dorsiflexion of my foot. Is that okay up to here?
Yeah.
Similarly, if I draw the back of my leg, lower limb, this is not present here. This is a posterior part, okay? And the posterior part is kind of one step ahead, okay? And you have the L5, L4, L4, L5 here, right? Then you have the L5, S1 here, okay? And then you have the S1 and S2 here, right? So if I ask that what nerve roots are involved in the plantar flexion of my foot, which means the Achilles tendon reflex, what nerve roots are involved in the Achilles tendon reflex? You can easily say these are the S1 and S2, right?
Yes.
If I ask you what nerve roots are involved in the knee flexion, these are the L5 and S1, right? And what nerve roots are involved in the extension of my hip? These are the L4 and L5. So remember, from L2 you have this you have the anterior part, and from L4 you have the posterior part, okay? And then you just need to add one numbers ahead, 4 5 5 1 and 1 2. For the anteriorly it will be 2 3 3 4 and 4 5, right? That would make it very easy to remember every reflex, okay? The knee jerk reflex or the ankle reflex, the Achilles tendon reflex is, right? That will make it very easy. Any doubt up to here?
No, thank you.
Okay. And one more thing. After this S1 and S2, the S3 and S4 lies in this region, right? Which causes the anal wing reflexes. If you guys remember the pudendal nerve, okay? This will be supplied by the S2 to S4. This is supplied by the S2 to S4. And that's why whenever you stimulate the S2 to S4, you can have an anal wing reflex, and that is by the pudendal nerve, if you guys remember. S2, S3, and S4, right?
Yeah.
So just choose a location which is L4, okay? Above L4, it will be the thigh. Below L4, it will be the leg. L3, L4, to be more to be exact, okay? L3, L4 supplying this region of the knee. After that, you will be having a L4 and L5. You will be having a before or the above. You will be having a L2 and L3. For the posterior part, at the knee side, you will be having a L5, S1. Below the knee, you will be having a S1 and S2. Above the knee, you will be having a L4 and L5. And above that, you'll be having a S2, S3, and S4 for the anal region, right?
Yeah.
So when we study the radiculopathies, we will discuss that again, right? And it will make it very easy to remember what these radiculopathies can cause what symptoms, right? If you remember this part only. If anyone has doubts up to this point, can ask. No? Anyone?
No, thank you.
So let's move forward. Then you need to remember about the knee, okay, the knee joint, okay, and what areas, what nerve roots supply the knee joint? What nerve roots supplying the knee joint?
L4.
L4 and L3 also, right?
Yeah.
And for the posteriorly, you will choose the L5. Anteriorly L4, posteriorly L5, right? L5 and S1. to be exact, and anteriorly L3 and L4 to be exact, right? So you have certain ligaments and certain tendons here, right? For that, you need to remember every one of them. Okay, so for the femur, as you can see here, you have this lateral condyle. This is a lateral part. As you can see, the fibula is here, and fibula is always lateral. Okay, so you have the lateral, the condyle of the femur, and you have the medial condyle of the femur. Okay, and below you will be having a tibia, which is medially, and the fibula, which is lateral. Okay, on this tibia, okay, you'll be having a lateral meniscus, and you'll be having a medial meniscus. Okay, the lateral meniscus is here, and this is the medial meniscus. Okay, you have two ligaments, important ones, which are the anterior cruciate ligament and the posterior cruciate ligament. The anterior cruciate ligament, it attaches at the anterior part of my the tibia. Okay, and the posterior cruciate ligament, it attaches on the posterior part of my tibia. Okay, and they always runs in the cross direction. As you can see, this is the part, this is the anterior cruciate ligament. It runs from posterior of my femur to the anterior of my tibia, from lateral to medial. Okay, so just remember, the anterior cruciate ligament, it runs from lateral to medial. Okay, if you're thinking, you need to set a reference value. Okay, and you will choose a reference as the tibia. In the tibia, the anterior cruciate ligament is attaching anteriorly and medially. Okay, and that means opposite in the femur. In the femur, it would be posterior and lateral. Similarly, the posterior cruciate ligament, it will be attaching on my tibia posteriorly and laterally. That means opposite in the femur, which is anteriorly and medially. Is that okay?
Could you please repeat these positions?
See, just set a reference in your mind, okay, and let's set the reference as the tibia. In the tibia, just know the location of this anterior cruciate ligament, which is anterior and medial, right?
Okay.
And just then do the opposite in the femur, which is posterior and lateral.
Okay. Okay. Yeah.
Okay, and similarly, in case of your posterior cruciate ligament, okay, set the value which is the lateral and posterior in my tibia. That means in my femur, it would be medial and
Anterior.
anterior. Not exactly properly anterior, but somehow anterior than the tibia. Okay.
Yeah. Yeah.
Okay. So that's about it. So from the lateral condyle of the femur to the anterior tibia, it would be the anterior cruciate ligament. From the medial condyle of the femur to the posterior tibia, it would be the posterior cruciate ligament. Just set a reference in your mind, the tibia, and then do the opposite in your femur. Okay. And yeah, please note one point, that the cartilage and the ligaments, okay, these are the avascular structures. They do not have any blood supply, right? And you guys know, in order to heal, I need the blood, I need the angiogenesis, right? So whenever any kind of injury happens to my cartilage or to my ligaments, okay, these cartilage and ligament will take so much time to heal because of the lack of blood supply. Step one will ask you this. I think it was NBME 24. I don't know what NBME asked this. Okay, but they have this question. They asked me about this. Uh, it was a patient who is having a damage to the ligament or the cartilage, and they asked, what would be the most important thing that will limit the healing of this cartilage or the ligament. So this will be the blood supply, because these structures lack the blood supply, they will have a very slow wound healing. Is that okay?
Yes.
Now let's discuss these signs. Whenever you have an anterior cruciate ligament injury or the posterior cruciate ligament injury, what's gonna happen, right? First discuss the anterior draw sign, in which your tibia is kind of moving anteriorly to the femur. With respect to femur, the tibia will be moving anteriorly. And see the function of the anterior cruciate ligament. If I draw the diagram, this is my femur, okay, and this is my tibia, okay. The anterior cruciate ligament, it is attaching at the anterior side of my this tibia, right? and it is going from posterior to anterior. Is that okay?
Yes.
So you can see that this ligament, this anterior cruciate ligament, is actually preventing the forward dislocation of my tibia.
Yeah.
So whenever I get a damage of this ligament, I can have a more forward movement of the tibia, right?
Right.
And this is the anterior draw sign. Whenever I have a damage to the anterior cruciate ligament, okay, my tibia will be anteriorly gliding, okay, with respect to the femur. And it is because of the anterior cruciate ligament injury. This is the anterior draw sign. Is that okay?
Yes.
Similarly, and this is your tibia, this is your femur again, okay, and you will be having this posterior cruciate ligament, okay. As you can see, this ligament actually preventing the backward dislocation of my tibia, right?
Yeah.
So whenever I get a damage of this ligament, okay, now my tibia can easily dislocate backward too much because the anterior cruciate ligament is here, okay. This is my anterior cruciate ligament. If my posterior one can get damaged, what will happen with the posterior dislocation of my femur? Sorry, with my tibia. Just give me a second. If my tibia get a posterior dislocation like that, this will be the position of my anterior cruciate ligament, right?
Yes.
And this is a damaged posterior cruciate ligament, right? So as you can see that this ligament, the PCL, is actually preventing the backward dislocation of my tibia, not the anterior this ligament. Similarly, my anterior cruciate ligament or the ACL is actually preventing the forward dislocation of my tibia. Whenever I get the damage of the ACL, I will get the more anterior dislocation, and this is the anterior draw sign. Similarly, when I get a damage of my posterior tibia, sorry, whenever I get a damage of my PCL, I will be having a posterior dislocation of my tibia, and this is the posterior draw sign. Is that okay?
Yes.
So please remember these draw signs. And if I'm having a posterior dislocation of my tibia, then what nerve I can get damage?
Tibial nerve.
Tibial nerve. So in the scenarios where you have this posterior, the PCL damage, in that case, you can also have impingement or a compression of this tibial nerve also, right? And whenever a tibial nerve can get damaged, what will happen? The patient will lose the tiptoe walking. Okay, they will lose the plantar, they will lose the sensations over the sole of the foot and the plantar flexion. Is that okay?
Yeah.
So remember this point. Similarly, you also have the Leishman test, in which instead of the 90-degree, you will bend the knee at the 30-degree only, not the 90-degree, okay? Then we talk about the two stresses, which is the valgus stress and the varus stress, okay? The valgus force or the varus force. In case of valgus force, it is will be the, this force will be from lateral to the medial direction, okay? The force from lateral to the medial direction is known as the valgus force, and the force from medial to lateral direction is known as the varus force. Okay, so if I force my knee from the lateral side, okay, like in this direction, in this section, if I force my knee, it will be known as the valgus force. If in this direction I force my knee from medial to lateral, it will be known as the varus force. As you can see, whenever I make a blow at my knee from the lateral direction to the medial direction, the medial cruciate ligament can get tear, right?
Yes.
And whenever I make a blow on my knee from the medial to the lateral side, that means a varus force, I can have a lateral cruciate ligament tear,
Yes.
and they will appear as the medial space widening or the lateral space widening of the tibia. Okay, so whenever you encounter a patient who is having this medial space widening, on applying a force from the from lateral to medial, that means the patient is having a MCL injury. If I get a widening of the tibia from the lateral side, whenever I apply a force on the medial side of my knee to the lateral side, okay, that means it is a lateral cruciate ligament injury. Sorry, the lateral collateral ligament injury. Is that okay?
Yes.
Remember these points also. Then you have this McCurney's test, okay, in which you check the damage of the lateral meniscus or the medial meniscus. Okay. Okay. So first I will ask the patient to make a flexion of the knee, a slight flexion. Okay. And then I will internally rotate it. Okay. I will internally rotate my leg. Okay. And apply a force, which is the varus force. Okay. So on the internal rotation and applying the varus force, if I get the pain, that means it is a lateral meniscus tear. Okay. And similarly, when I do the lateral rotation, whenever I do the lateral rotation, okay, while applying the valgus force, which means a force from lateral to medial, okay, and I get a pain, that means it is a medial meniscus injury. Okay. So the very easy way to remember is just think about the varus force or the valgus force. Varus force is always from medial to lateral, right? So if I make a blow on my knee from medial to lateral, then the lateral meniscus will tear first. Similarly, if I make a blow from lateral to medial direction, okay, which means a valgus force, I can have the medial meniscus tear. Is that okay?
Yes.
Same thing goes for the these injuries, the MCL and the LCL injury also. For the valgus force, the MCL injury. For the varus force, LCL injury. Right?
Yeah.
Okay. Now, any doubt on this page?
No, thank you.
So the step one will mainly just ask you about these tests. They will give you a patient who is having an anti-gliding of the tumor of the of this tibia, or having a posterior gliding of this tibia. They will ask you, and sometimes instead of giving the tibia, they can also talk to you about the femur. That the femur is more anterior as compared to the tibia, or the femur is more posterior as compared to the tibia, right? So just remember about these signs, right? They will also ask you about this widening of the space. If you're having a space widening on the medial side, that means it will be a blow from the lateral side. If I'm having a increase in the space on the lateral side, that means I took a blow from the medial side. That's all they will ask you about in this page. Then you have the ankle sprains, and the only thing that you need to remember for that is, the most commonly ankle sprain is in the anterior talofibular ligament, okay, which is a ligament between the fibula and the talus. You have the talus bone here, and you have the fibula here, okay. And whenever you cause a over inversion of your foot, as you can see, whenever I make the inversion, because this is lateral and the tibia is medial, whenever I do the inversion, I'm stretching this lateral part, right? So as a result, that this lateral part will be more prone to damage in this condition. And the most common site of the damage is the talofibular ligament. Okay, and the other ligaments are the calcaneofibular, okay, the posterior talofibular, okay. So yeah, the most important one is the talofibular, which is the anterior one, okay, and it happens because of the hyper inversion of my foot. Is that okay?
Yeah.
So remember just this fact: the most common ankle sprain occur during the foot inversion, and it is because of what damage to the anterior talofibular ligament. Okay, very important. Any doubts so far?
No, thank you.
I think we should take a short break, and then we'll study this radiculopathy. Okay, after a short break of 5 to 10 minutes, we will study radiculopathy. Okay.
Recording.
Okay, so the radiculopathy is basically nothing but just a compression of the nerve roots. Okay, when they exist the spine, okay, somehow when the nerve roots can get compressed, and whenever they get compressed, the associated structures supplied by these nerves, okay, they will get damaged, right? And they will cause the symptoms, and this is known as the radiculopathy. Okay, it causes paresthesias and weakness, which is related to a specific lumbosacral spinal nerves. Okay. Then you can have a radiculopathy or the compression of these nerves. Okay, it could be due to a vertebral disc herniation, which generally causes a acute type of this radiculopathy, or it could be due to the spinal spondylosis. Spinal spondylosis, okay, in which an anatomical change happened to your vertebra, any kind of a remodeling. As a result, the space through which these nerves need to exist, this space will get narrowed, and because of this narrowing of the space, you will get the compression of the nerve, and that will cause the symptoms of the radiculopathy, right? So the intervertebral disc herniation, okay, it generally happens the posterior laterally throughout the through the annulus fibrosis, which is the outer ring of the central canal. Okay, and it happens due to a thinning in the posterior longitudinal ligament, which is present in your spine. Okay, and the thick anterior longitudinal ligament. Okay, in the anterior side of your vertebra, you're having this thick, you're having the anterior longitudinal ligament. On the posterior side of your vertebra, you're having the posterior longitudinal ligament. Because of a thick anterior longitudinal ligament and a thinner posterior longitudinal ligament, you can have the herniation of the disc posteriorly, right? And that can compress the nerves, that can cause the damage. Okay, and yeah, as you can see, in case of the lumbar vertebrae, okay, let's suppose this is a L5. Okay, just above the L5, you have the L4 nerve exist, and below the this L5, you're having a L5 exist. Okay, so every corresponding this nerve root, they will exit, okay, after the corresponding disc. Like for the L4 nerve will be exit after the L4. Similarly for the L5 nerve will exit after the L5 spine, right? Now, whenever a disc is herniated, okay, it will compress or it will damage the nerve after the disc herniation, which means if if the L4 or L5 nerve get if the disc between the L4 or L5 can get herniated, in that case the L5 nerve will be affected. Okay, similarly, if the disc between the L5 and the S1 is herniated, okay, then the S1 nerve is affected first. Is that okay? Up to here? Yes.
Yeah.
And whenever a space between the L4 and the L5, the anatomical space between the L4 and L5 due to any spondylosis, okay, if that space can get narrowed, okay, then this nerve which is exiting the space, which means a space between the L4 and L5, the L4 nerve will be exiting. In that case, this L4 nerve will get damaged. Okay. Similarly, if the space between the L5 and the S1 can get narrowed because of any spondylosis, in that case, the L5 will be affected first. So for a disc herniation, it is always the below, okay, which means between the L4 and L5, the L5 will get damaged. In case of a space narrowing because of the spondylosis, okay, the upper one will be affected, which means the L4 in case of L4 and L5. Is that okay?
Yes.
Okay, now see, if you're having an impingement of the nerve or the nerve root from the L4, then what symptoms you can affect? For example, if you're having a herniation on the L3 and L4, then the L4 nerve will be compressed. And because of this L4, where you can get the symptoms, you will get the symptoms first in the knee. Okay, the extension of the knee will be affected, as well as the dorsiflexion of the foot will be affected. So what you will have is a loss of plantar reflex and the weakness in the knee extension. Similarly, if a disc is herniated between the L4 and L5, then the L5 nerve will be compressed. And as a result, where you will get the symptoms? You will get the symptoms in the foot part, Okay, the L4 and the L5 supplied here, right? So what you will have is a weakness in the dorsiflexion, because you know that the L4 has a major activity on the knee, right? Below the knee, it will be the, below the L4, it will be the leg part, the L5 supplies here. Above the L4, it will be the L2 and L3 supplying the hip part, right? So whenever I say the L4 is damaged, which means the major effects will be on the knee. Okay, when the L5 is damaged, the major effects will be on the foot part, right? So it will be a difficulty in the dorsiflexion. So heel walking will be affected. Similarly, if the disc between the L5 and the S1 is herniated, in that case, the S1 will damage first. Okay, and the S1, you guys know, in the posterior region supplying the Achilles tendon site. And as a result, you will have a loss of Achilles reflex. You will be having a difficulty in the toe walking, right? Because this posterior part, this part is supplied by the S1 and S2. Is that okay?
Yes.
Okay, any doubts so far about these things?
No, thank you.
And this is basically the cause of your the radiculopathy. Okay, it could be an acute type, it could be a chronic type. The chronic type generally involves the spinal spondylosis, okay, in which you're having a pathological remodeling of the vertebrae, and as a result, the space between the space for the exit of the nerve will get narrowed, and as a result, the nerve will be compressed. It will be due to the degenerative changes of the vertebral bodies or the discs or the joints. It is always subacute in the onset. Okay, generally takes 2 to 8 weeks, which means around 2 months to develop. Then you have the acute radiculopathy, in which the symptoms are acute in onset, and these are mainly due to the vertebral disc herniation. Okay, sometimes it can happen due to the weightlifting. Okay, it would be a patient who was lifting the weight and suddenly he feels a pain in the back, and and shortly after the pain, the patient is starting having these paresthesias or the burning pain and the weakness in the lower limbs, right? So whenever the acute symptoms are there, that means it is due to the disc herniation. And whenever the chronic symptoms are there or subacute symptoms are there, I must say, these are due to the spinal spondylosis. Okay, what you will get is a sensory defect, which means a dermatomal region to which this nerve root is supplying. You will get a burning pain there, you will get the loss of senses there. You will get the motor deficits in that area. We have discussed these scenarios, right? And please note that these signs and symptoms are not located to the nerves, but the nerve roots. Okay, we are not talking about a tibial nerve or the fibular nerve damage. We are talking about a nerve root damage. So all these symptoms, they generally involve the dermatomes. Okay, sometimes 2 or 3 dermatomes can also be involved, right? The radiculopathy can be the cervical radiculopathy, okay, in which you are having a damage in the cervical roots, okay, cervical nerve roots, which causes mostly the shoulder pain and the neck pain. You can have a lumbar radiculopathy. You can have a thoracic radiculopathy also, okay, and you have something known as the sciatica, okay, in which the radiculopathy involving the nerve roots which are for the sciatic nerve, right? And as a result, the patient will have the pain which is radiating all the way down to the leg in the location of the sciatic nerve, okay, in the distribution of sciatic nerve, right? The patient will get the pain in the distribution of the sciatic nerve, and that is known as the sciatica. It will be a radiating pain, shooting type of pain will be there, right? And the pain will go all the way down to the leg uh, in the regions which are supplied by the sciatic nerve. This is known as a sciatica. Is that okay?
Yeah.
And the radiculopathy can also occur due to the epidural tumor. Please note the tumor location. It is the epidural tumor which can cause the radiculopathy. Okay. Any doubts so far?
Could you please explain that epidural tumor, how it can cause radiculopathy?
It's just the outermost part, this epidural is the outermost part of your
Meninges.
outermost layer, right, of the meninges. Okay, so I don't know, just happened here. I really don't know why the epidural tumor is causing it. It may because it's the outermost part, and that's why, because the other layers are kind of very much inner to that, right? So because it is outermost, that's why maybe it is happening.
Okay, no problem. Thank
And
you.
because it is outermost, and it will be in a very close association with this nerve, right? Maybe that's why.
Yeah, right. Thank you.
Okay, then you have the spondylolisthesis. Okay, spondylo means vertebra or the spines, and listhesis means the movement. So in this disorder, you will be having a movement of your vertebrae, okay, with respect to other vertebrae. Generally, you have the vertebrae which are very much kind of joined to each other, and they cannot move like that, right? Well, they can rotate, but they cannot move anteriorly or posteriorly, right?
Yeah.
Now, in case of a spondylolisthesis, okay, you will be having the anterior or the posterior movement of the vertebrae with respect to each other, and it is because of the weakness in this disc, okay, and a fracture that involves the pars intercruris. Okay, you have a location in the spine which is known as the pars interarticularis. If the fracture of this pars interarticularis happens, as you can see this part, this is the pars interarticularis. If the fracture happens, then this vertebra, and let's suppose this fracture happens in the L5 maybe. Okay, so now this L4 can easily move forward with respect to the L5, right? And this is known as a spondylolisthesis. So if they ask you about a patient who is having a lower back pain, okay, and on the X-ray or on the MRI of the patient, there will be a forward movement of the upper vertebra with respect to a lower vertebra, right? And just give me a second. So that's how you know the patient is having a spondylolisthesis. Is that okay?
Yeah.
Okay, so spondylolisthesis is the anti-displacement of the vertebral body. Okay, the most common cause is basically the fracture of the pars interarticularis. Okay, and yeah, the patient will get the chronic back pain. In the X-ray, you can see the anterior displacement, okay, as well as a tenderness over the region. So these things, whenever you get, you will always think about the spondylolisthesis. Generally, the patient will be asymptomatic without, apart from the pain, the patient will have no history, but sometimes because of the nerve compression also, the patient can get the radiculopathy also. Sometimes just the pain, sometimes the radiculopathy along with the pain. Okay, this is about the spondylolisthesis. Any doubt?
No, thank you.
And now you need to know about the neurovascular pairing. Okay, in which there are certain nerves which are always accompanied by the arteries. That means the arteries and the nerves are very close association. In that case, whenever a nerve damage happens, okay, the artery will also damage along with them, right? And you need to know that in the axillary lesion, you have the long thoracic artery. Sorry, you have the long thoracic nerve of Bell, right? And it is always associated with the lateral thoracic artery. So whenever I have a damage of the long thoracic nerve, I will also have a damage of the lateral thoracic artery. For a surgical neck of humerus, we have discussed that about the axillary artery and the posterior circumflex arteries, right? The
Yeah.
anterior and the posterior circumflex artery. Whenever you get a damage of the axillary nerve, you will also get a damage of posterior circumflex artery. And that's how you can get a avascular necrosis of the humerus also, of the head of the humerus. Then for the mid shaft of the humerus, along with the radial nerve, you have the deep brachial nerve. Okay. For the distal humerus or the cubital fossa, you have the median nerve accompanied by the brachial nerve. So brachial nerve for the medial nerve and the deep brachial nerve for the radial nerve. Then you have the popliteal fossa. Okay. And for the popliteal fossa, we have discussed the tibial nerve and the popliteal nerve. You have the tibial nerve there, just posterior to the tibial bone. Okay. And then it is always accompanied by the popliteal nerve. Okay. Then posterior to the medial malleolus, you have the tibial again, the tibial nerve, and it is accompanied by the posterior tibial artery. So step one will give you a patient, and they will describe you some symptoms which are corresponding to any of the nerve damage, and they will ask you that what artery can get damaged because of this symptoms or because of this presentation, right? Because of this cause, what arteries can damage bigger along with these nerves. So you need to remember the neurovascular pairing for that. What arteries are paired with what nerves, right? Very important. Any note on this page?
No, thank you.
Okay, now let's discuss how the muscle contraction happens whenever my motor nerves supplies, whenever my motor nerves is stimulated, okay, and they release the acetylcholine. How the how the muscle contraction actually happens. So first you need to know about the T-tubules. Like you have these gap junctions. Remember the connexons in different cells.
Yeah.
Okay, what does this connexons do?
Allows passage of ions and molecules.
And what would happen because of that?
For a complete mechanical contraction of the heart that's required.
Coordinated mechanism, you can say, right?
Yeah.
For a coordinated movement or a coordinated contraction to happen, I need the connection between the cells, right? So that the ions can easily pass and they cause a regular or a normal, a coordinated contraction. So I have the connexons for that. But the connexons are absent in the skeletal muscles, and in the skeletal muscles, I have T-tubules instead. And these are the extensions of the plasma membrane, which are connected with the sarcoplasmic reticulum. Okay, you have the plasma membrane around this, which is a sarcolemma, right, along the this muscle fiber, right, and every muscle fiber contain a sarcoplasmic reticulum, right. So these are the invaginations or the extensions of the plasma membrane, like that, as you can see, which are connected with the sarcoplasmic reticulum, and they allow the coordinated contraction of the striated muscles. Is that okay?
Yes.
Function of tubules. So now, as you can see, whenever the nerves are stimulated, okay, they will release the acetylcholine from them. Okay, and when the acetylcholine are released, they will first stimulate the acetylcholine receptors. Okay, and as a result, the depolarization of this membrane happens. When the depolarization happens, okay, this action potential will travel along the membrane. It will go to the T tubule. Okay, and from the T tubule, it will stimulate the receptors known as the DHPR receptors, which are the dihydropyridine receptors. Okay, dihydropyridine receptors, and these are the calcium channel receptors. Remember two type of receptors for the calcium channels?
L type and T type.
And two more for the same category, the dihydropyridines and the non-dihydropyridines, right?
Yeah.
Remember the calcium channel blockers, two types.
Yeah.
Okay, so these are the, yeah, so these are dihydropyridine calcium channels will be stimulated. Okay, and when they're stimulated, they will stimulate the ryanodine receptors. Okay, so after the DSPRs are stimulated, they will be coupled to the ryanodine receptors, and when the ryanodine receptors are activated, they will cause the release of this of the calcium in the cytoplasm of the muscle fiber. So the DHPR receptors, they are found in the cell membrane. Okay, and the ryanodine receptors are found in the sarcoplasm. Found in the sarcoplasmic reticulum. Okay, when the plasma membrane is stimulated, the DHPRs are stimulated. They will stimulate the this ryanodine receptors, and as a result, all of the calcium will be exit within the cytoplasm. Is that okay? Up to here?
Yes.
And when this calcium enters the cytoplasm, it will first go to the troponin C. Okay, so you have the myosin, you have the actin. On the actin, certain proteins are found which are known as the troponins and the tropomyosin. Tropomyosin, it functions as the it covers the active sites present on this actin molecule. Okay, on the actin you have these some active sites. Okay, and whenever the active sites are exposed, this myosin can bind to these sites and can cause a contraction. So the function of this tropomyosin is to cover these active sites so that the myosin cannot be bind to the actin. Okay, apart from the tropomyosin, you have the troponin C also. Okay, the troponin T, the troponin C, and one more troponin I'm Forgetting the name.
I.
Anyways, but I. So this calcium binds to troponin C, and as soon as the calcium binds to the troponin C, this tropomyosin will be removed from the actin and the active sites are exposed, right? And whenever that happens, the ADP will bind to the the ATP will bind to the myosin, and the myosin has the ATPase activity. It will use the ATP, okay? It will degrade the bond between the ATP and the phosphate, and as a result, it will release the phosphate and the ADP. And this will provide the energy for the muscle contraction. As soon as the ATP is hydrolyzed into the ADP, this myosin will bind to the actin and it will cause the contraction. Is that okay up to here?
Yeah.
So I need the calcium as well as the ATP at the same time to cause the contraction. Calcium to expose the active sites and the ATP to activate the myosin, right? And when the contraction is over, then again one ATP will bind to the myosin and it will remove the ADP, and as a result the contraction will be over. So to cause the contraction, I need the ATP, and again to remove to uh, to cause the relaxation, I again need a ATP, right? And when this ATP is again hydrolyzed, the ATP which is binded to remove this myosin from the actin to cause a relaxation, when this ATP is again hydrolyzed, I can have another contraction. Is that okay?
Yeah.
So please note, you need the ATP to cause a relaxation. Okay, as soon as the myosin binded to the ATP, okay, it will cause a relaxation, and when this myosin again hydrolyze the ATP, again the contraction can happen, right? So can anyone tell me the frequency of my contraction is dependent upon which factor?
Calcium.
Not the calcium.
Number of times it getting depolarized.
Any other thing? See, one thing is duration and one thing is a frequency, right? The duration of my contraction is depend upon for how much duration the calcium is available in the cytoplasm. If the calcium is available for a longer duration, then for the longer duration my troponin will not be available, and that means these active sites are exposed. As long as I have the calcium in the cytoplasm, these active sites are exposed and I can have a contraction. So the duration of contraction actually depends upon this calcium levels, but the frequency of the contraction is dependent upon this ATPase activity. Even if the calcium is there, I can have the contraction only when the myosin hydrolyzes the ATP, right?
Yes.
So if the speed of hydrolyzing this ATP is more, then I can have a more frequency of the contraction.
Yeah.
So the frequency of contraction is dependent upon the activity of this ATPase, and the duration of the contraction is dependent upon the calcium. Okay.
Yes.
Now let's talk about the energy for the muscle contraction. We have discussed that part already in the biochem section. Okay, but let's again discuss this. For the first few seconds, you have this creatine phosphate in the in the muscles. Okay, and the creatine phosphate will supplies the ATP to the muscle. Okay, and that will cause the contraction in the first few seconds. Once the ATP is is used completely and the creatine phosphate is also depleted, okay, then this muscle will start using this anaerobic glycolysis. Okay, all the glycogen which is stored in the muscle, it will be converted into the glucose, and the glucose then converted into the lactic acid, and this is known as the anaerobic glycolysis. Okay, it will provide the energy to the muscle for the first 60 seconds, after 10 seconds up to the 60 seconds. After 60 seconds, the muscle realizes that because this lactic acidosis will form only 2 ATPs, right? So not enough energy. Yeah. In order for the muscle to function more, it requires the ATP, right? And the only way to get a maximum number of ATP is to use the TCA cycle and then the oxidative phosphorylation, right?
Yes.
And that's after 60 seconds, the muscle will switch the anaerobic glycolysis into the oxidative phosphorylation, which means the aerobic glycolysis. Okay. So the energy for the first 10 seconds, it came from the creatine phosphate. The creatine phosphate will be converted directly into the ATP, and it will cause the contractions. For the next 60 seconds, it will be the anaerobic glycolysis, and that's why you have the lactic acidosis. After 60 seconds, the muscle start using the oxidative phosphorylation. Is that part clear?
Yeah.
So sometimes step one can give you a question like, whether whoever is studying a muscle, okay, and what they have noticed that, when the muscle is starting the contraction, then up to the first few seconds, the ATP levels are normal in the muscle. Absolutely normal. No depletion in the ATP is seen. So they ask you what could be the source of this ATP, or what could be the reason behind the normal values or a normal level of this ATP. So please note, it is because of the creatine phosphate. This creatine phosphate will be converted into the ATP, maintaining the normal levels of ATP for the first 10 seconds. Is that okay?
Yeah.
Just know at what seconds, at what time, what energy substrates are being used. Okay, very important. And let's discuss on the further levels, what will happen to the contraction bands. Okay, so you have the sarcomere. Okay, within the muscle fibers, you have a muscle fiber which is a muscle cell. Within these muscle fibers, okay, you're having these sarcomeres, and multiple sarcomeres will form these muscle fibers later on. Okay, so the unit of the muscle fiber is basically the sarcomere, right? And the sarcomere is basically a distance between the two Z lines. Okay, uh, yeah, just give me a second. Yeah, this darker line you're seeing here. Okay, this darker line, this is a Z line. Okay, and the distance between the two Z lines is known as the sarcomere. Okay, and then these Z lines, it will appear very dark in the electron microscopy. As you can see, it will appear very much darker. Okay, then you have this lightest region. Okay, this lightest region, it consists of only the actin filaments, as you can see. Okay, and you call it the I band. So the I band contains only the actin filament. Okay, then you have a region, okay, which is completely dark, as you can see, the darker region, and this region known as the A band. Okay, and it consists of the myosin filaments. As you can see, it consists of the myosin filaments, right? And then in the center, you're having again this lightest region. In this darker region, which consists of the myosin and the actin, you have this lightest region here in the center, and this is known as the H band, and this H band represents the M line. Okay, the myosins are kind of attached to each other with the help of this M line. So M line help in the attachment of the myosin, right? And it appears as the very lightest region known as the H band. So remember the H band, which is in the center, I band, which is a lighter band, and the A band, which is a darker band. And then you have two Z lines. In between the two Z lines, you are having the sarcomere. So whenever the muscle contraction happens, these two Z lines will getting close to each other, right? And as a result, this lightest region, because the whenever the contraction happens, more of the actin will be overlapping the myosin for the contraction, and as a result, that the size of this I band will be decreased. Is that okay?
Yes.
And after when the contraction happens, okay, because the size of the myosin will always remains the same. Doesn't matter when you're having a contraction or a relaxation, right?
Yes.
Every myosin is of a fixed size. So even after a contraction, the size of this band, the A band will remain same. Okay, because the size of the myosin will remain same, right? But the distance, the sarcomere, the Z to Z line distance, it will decrease, right?
Yes.
So during a power stroke, what gonna happen? Uh, yeah, yeah. Just give me a second again. And this H band, look at the H band. If more of the actins overlap this area during the contraction, can I say the size of this H band is also decreased? When more of the when more of the actins overlap this area, then this lightish band you are seeing here, it will disappear, right?
Yeah.
So you can say that during the contraction, the H band, I band, and the distance between the two Z lines, it will decrease.
Yes.
And during the contraction, again, during the power stroke, you will have a normal A band. Yes.
Yeah.
And this ADP is released after the end of power stroke, and a new ATP is bounded, which we have discussed. And when the new ATP is bounded, okay, the myosin is released from the actin, right? And the relaxation can happen. And when the myosin again hydrolyze the ATP, then again a power stroke can happen. Similarly, you will have a shortening of this H band, I band, and the Z to Z line, normal length of the A band. Is that okay?
Yes.
So remember these facts, very important. Yeah, that would be all about it. Any doubt?
No, thank you.
Then you need to know about the muscle fiber. Can anyone tell me what the muscle fiber is?
The muscle cell.
A muscle cell, exactly. A muscle cell is known as the muscle fibers, right? And this muscle fiber contains these sarcomeres, multiple sarcomeres, cytoplasm, all these organelles. Okay, so this constitutes of the muscle fiber. You have two type of muscle fibers or the muscle cells: the type 1 fiber and the type 2 fibers. Okay, the type 1 fibers are the slow contracting fibers, and the type 2 fibers are faster contracting fibers. Whenever you need the endurance, that means a very prolonged contraction, like say the running, or to maintain the posture, you need the type 1 fibers. Whenever you need the acute contraction, like the weight lifting for say, like gym, okay, in that case you need the more of type 2 fibers. So type 1 fibers are used for the endurance, and type 2 fibers are used for the weightlifting. And because you guys know, in order for the muscle cell to contract for a prolonged duration of time, they require the oxidative phosphorylation, right?
Yeah.
So that's why the predominant metabolism in case of type 1 fibers is the oxidative phosphorylation, so that a sustained contraction can happen, right? While in case of a type 2 muscle fibers, it would be the anaerobic glycolysis. Is that okay?
Yeah.
These muscle fibers are type 1, they will appear red because of presence of more myoglobin and the mitochondria, right? And the type 2 fibers, they appear white because of low myoglobin and low mitochondria. Okay. The type of training is the endurance. Okay. And the type of training in type 2 is the weightlifting. Okay. Or the resistance training. Okay. These muscles are not fatigable. Type 1. Type 2 muscles are, but these muscles are very much easily fatigable. Okay. So, yeah, that would be all about this type 1 and the type 2 fibers. Any doubt?
What's that which you have written about fat and glycogen?
See, these muscles are very much rich in the fat. Okay, they need the oxidative phosphorylation. So these muscles are very much rich in the fat, while the type 2 muscles, they are rich in the glycogen. Okay, because the fat will be converted into the glucose. Okay, and the glucose will be used by the cell again, right? And again, the ketones similarly, right?
Yeah,
So
yeah.
they have a very increased fat content, and the type 2 have the increase in the glycogen content. The glycogen will be converted into glucose. Okay, and then the glucose will be converted into the anaerobic glycolysis, right?
Yeah, yeah. Okay.
So, and yeah, and does anyone tell me, can these muscle cells undergo the hyperplasia ever?
No.
So whenever you do either the weightlifting or you do the endurance training, please note that the phenotypic character changes with the, although the phenotypic characters of these cells will change, okay, the number of the muscle fibers will always remain same. Even after the endurance training or the weightlifting, okay, you have a grown in the muscle mass, right? But this growth in the muscle mass is all due to the hypertrophy, not due to the hyperplasia. So the number of muscle fibers, they always remain same, but the size of these muscle fibers are increased because of the hypertrophy. Is that okay? Step 1 will try to trick you into this. They will ask you, they will give you some options like the muscle fibers are increasing or decreasing after this endurance training, right? Or the size is increasing. So it will be the size, okay, not the number. Number will always remain same because they cannot divide, right?
Yeah.
So please remember this fact. Any doubt?
No, thank you.
Okay, then you have the contractions of the smooth muscle. Although we have discussed that already in the CVS section. Okay, first you have the this influx of the calcium. The calcium will bind to the calmodulin, forming a calcium calmodulin complex, and it will activate the myosin light chain kinase. Whenever this light chain kinase is activated, it will cause a phosphorylation of the myosin. Okay, and it will cause the uh, this contraction, right? And then you have the phosphatase enzyme, which will remove the phosphate from the myosin and the actin complex, and as a result, the relaxation will occur. The nitric oxide will cause that, the activation of MLCP, okay? And then the other agents like the cyclic AMP inhibits this myosin light chain kinase, so they can cause a relaxation again. That we've discussed already completely, right? The contraction of the smooth muscles. Yeah?
Yeah, yeah.
Okay, so any agent which increases the calcium levels in the cell, they will cause a contraction. And any agent which is increasing the nitric oxide in the cell, okay, or the cyclic GMP or the cyclic AMP, they will be causing the relaxation in the smooth muscles, okay, in the vessels mainly. For the relaxation in the skeletal muscles, you're having this SARCA, okay, which is sarcoplasmic reticulum calcium uh, channels, okay, and they will cause an influx of the calcium from cytoplasm into the this sarcoplasmic reticulum, right? While in case of a cardiac myocytes, they have both the SARCA as well as the sodium calcium pump. Remember the sodium calcium pump, which will cause the efflux of the calcium and the influx of the sodium,
Yeah, yeah.
right? So in case of cardiac myocytes, you both have the SARCA as well as the sodium and the calcium pump, right? But in case of skeletal muscles, you only have the SARCA. And the skeletal muscles, they only dependent upon the intracellular calcium, while these cardiac muscles or the smooth muscles, as you can see, they're dependent upon the external calcium delivery, right? So whenever I give the patient these calcium channel blockers, they have the effect on the cardiac myocytes and the smooth muscles, but no effect on the skeletal muscles, because the skeletal muscles are not dependent upon the external delivery of the calcium, right?
Yeah.
So note this fact also, very important. Okay, now comes the muscle proprioceptions, right? And yeah, so how does the sensory receptors on the muscle relay information about the muscle dynamics? Okay, in what positions your muscle are, at what angle is between the two muscles and between the joints, right? How this information is being transferred to the CNS. Okay, this is a muscle proprioceptions, right? And so you have two type of receptors in the muscles. One is the muscle spindle, and second is the Golgi tendon organ. These are the two type of receptors are which are found in the muscle fibers. Okay, whenever the length of the muscle is increased, okay, or the speed of the stretch is increased, okay, as a result, what gonna happen? The information will be travel with the 1 alpha or the 2 fibers. Okay, you have the 1 alpha fiber, you have the second 2 fibers. Okay, these are originated from the muscle spindle. They will take the information from the muscle, go to the dorsal horn, as you can see, the dorsal root ganglion. Okay, from the dorsal root ganglion, it will reach to the dorsal horn, as you can see. In the dorsal horn, it can do two things. Okay, let's suppose I want to do the flexion. Okay, that means my flexor groups must be activated. Okay, and my extensor groups must be inactivated, right, to cause a flexion.
Yeah.
So whenever I stimulated this part, whenever I want to do the flexion, okay, what these fibers do, they will activate the inhibitory neurons as well as the activatory neurons. You have the Rancho cells in this spinal cord. Okay, and these are the inhibitory neurons. Remember the Rancho cells from the microbiology? The tetanus?
Yeah.
Right. The tetanus inhibit these cells, right? So that the powerful contraction can happen that can lead to the spasms, right? So these interneurons or the Rancho cells, they releases the inhibitory neurons that causes the inhibition of the antagonist muscle group, which means in this case, the extensor muscle groups, because I want to do the flexion. While a direct synapse happen between the motor neurons and these types and these proprioception fibers, and as a result, they will activate the flexor groups. Okay, so flexor groups are activated and the extensor group is inactivated because of the Rancho cells, right? And that's how a muscle contraction happens. Is that okay?
Yeah, but what's the role of muscle spindle in this? Like, how can the muscle itself send signals?
I have a weight in my hand. That means I want to contract, right?
Yeah.
So these stretch, whenever I have a weight in my hand, what's going to happen? The length of my fibers will increase because of the stretch.
Yeah.
Okay, and whenever this length is increased, okay, these muscles, these spindles will get activated and they will tell to cause the contraction. Okay.
Yeah, I got it now.
So
Thank you.
it's about the reflex.
Yeah, yeah.
Remember the reflex pathway, this is a reflex pathway actually. The knee jerk or the Achilles tendon reflexes. Okay, these are all start with the muscle spindles first. When you make a jerk, okay,
Yeah. Okay. And
when you tap on the
and
when you tap on the knee, yes, ask.
I'm asking, is there any role of Golgi tendon is in this reflex pathway?
We will discuss that later. Don't worry, you will know that.
Oh,
Okay, so whenever my spindles are activated, for example, I tap on the muscle for the jerking. Okay, so these spindles are activated. Okay, they will cause the contraction by all these alpha 1 fibers and the 2 fibers. Okay, they will go to the dorsal root ganglion, then to the dorsal horn, activate the Rancho cells and activate the these motor neurons. And please remember, the motor neurons are the alpha fibers. They have a very high speed and a high conduction. That's why they will cause a contraction without any delay. Okay, or with a very minor delay, they can cause a contraction, right? Alpha fibers have a very high speed, right? So for every reflex that you know in the muscles, it is all because of these muscle spindles. Okay. Then
okay.
second type of the second type of receptors you have is the Golgi tendon organ. Whenever the tension in my muscle increase, for let's suppose I want to lift a weight. Okay, I'm lifting a weight, but I know that this weight is too much for my muscle to handle. Okay, and if I lift this weight, then my muscle can get damaged because of that, right? And how does my muscle know about it? It is because of tension. Whenever I lift a heavy weight, the tension in my muscles will increase. And when this tension reaches a certain limit, this Golgi tendon organs will get activated. They will transmit the information via the dorsal root ganglion and then to the dorsal horn, and they will activate the Rancho cells again. And when the Rancho cells are activated, okay, they will travel, they will cause the relaxation by inhibiting the alpha motor neuron, right?
Yeah.
So whenever the tension in my muscle is increased because of a heavy weight lifting, okay, what's gonna happen? The Rancho cells will activate it because of the this Golgi tendon organ, and as a result, the contraction of my muscles is inhibited, right? So this is just to make sure that my muscle won't get damaged because of this high tension. A protective mechanism is exist. Is that okay?
Yeah.
In case of any upper motor neuron lesion, these Golgi tendons will be hyperactivated. So even if you lift a very little weight, okay, then these Golgi tendons will send the impulses to these Rancho cells, and the Rancho cells will inhibit the contraction. Okay, so even a slight tension is occur to your muscles, what you will get is the relaxation of the muscles, right? And this is exactly happen in the upper motor neuron lesions. It is also known as the clasp knee reflex. Okay.
Could you please explain once again why upper motor, like how it is the upper motor is controlling the this Renshaw cell?
See, the major function of this upper motor neurons is to control the Rancho cells only. Okay, whenever the upper motor neurons are damaged, they cannot control the Rancho cells, and as a result, you will have these spasms. Okay, because Rancho cells are now inhibited. That's why in the case of upper motor neuron lesions, you will be having the spasms in the first place.
Okay, I got it now.
Okay.
Yeah, thank you.
So, and please remember the fiber name from the Golgi tendons. These are the 1 beta fibers. So 1 alpha fibers from the spindles and 1 beta fibers from the Golgi tendons. Okay, and it is always the alpha neurons, which are the motor neurons. Okay, which will relay the information from the spinal cord to the muscles, right?
Yes.
So tell me, if I damage my muscle in spindles, can I get the paralysis? If I damage my muscle spindles, can I get the paralysis?
Yes.
Why?
Because it will not be able to sense any pull, and then if it is not able to sense any pull, it will not cause any kind of contraction in the muscle.
See, this contraction pathway is actually the reflex pathway. The
Yeah.
viscous, these Achilles reflex, the knee reflexes, it is all because of this pathway, right?
Yes.
I still have the motor neurons. I still have the upper motor neurons. The voluntary contraction is begin in the CNS, right? In the brain.
Yes.
And from the brain, you have these upper motor neurons, and then you have the lower motor neurons, right?
Yeah.
These lower motor neurons are these alpha fibers actually. So I still have the brain, okay, intacted. I still have the alpha motor neurons intacted. If I damage my muscle spindles or this 1 alpha or 2 fibers, then I can still get the contraction but I won't get the proprioception, right?
Yes. Yes.
My proprioception is inhibited. I cannot sense if anything is happening to my muscles. But when I want to make a contraction, I can easily make it because my CNS is intacted, right?
Yeah.
My reflex is now inhibited.
Right.
If I want to make a reflex, if I want to make a knee reflex or the jerk reflex, any Achilles tendon reflex, then this reflex is inhibited because these fibers are required to cause a reflex. So whenever I have a damage of these muscle spindles, I can have a loss of reflex, but a normal contraction is there. Similarly, if this dorsal root ganglion is inhibited or destroyed, can I get the paralysis again?
No.
No, I won't. And that's why you will study that later again in the neurology section. If I damage my these dorsal columns, okay, or the dorsal root ganglion, I just lost my proprioception or the sensory input. But my muscle contraction is still remain normal, and my deep tendon reflexes, they are inhibited. If you can refer that to the this whatever in the syphilis, the tabes dorsalis, remember?
Yeah. Yeah.
In syphilis, in the tabes dorsalis, you will be having a damage to the columns and the dorsal root ganglion. Okay, you will be having an areflexia, but the muscle contraction was absolutely normal. Okay,
Yeah.
but if the motor neurons are damaged, upper motor neuron or the lower motor neuron, in that case, you can get a paralysis. Okay,
Yes. Yes.
so please note the difference between these pathways. These are all just for the reflexes. Okay, if you have a more weight, you want to make a contraction, the signals for the contraction will originate in the CNS, right?
Right.
But how much contraction is needed, it will be decided by these fibers, these spindles. If I have more length, that means I need a more contraction. Signals are originated from the CNS, and I will get a more contraction because of these spindles, right? But if the spindles are not there, that I cannot sense how much contraction I needed now. But the contractions is normal, absolutely. Okay, it just I cannot sense it now. Okay,
Yeah. Yeah.
so that would be all about these two receptors. Any doubt?
No, thank you.
Okay, so we have finished with the muscles, and now we start the bone. Okay. Okay, so for the bone, you have this endochondral bone ossification as well as the membranous bone ossification. In the endochondral bone ossification, first the these chondrocytes will come, okay, or the chondroblast, you can say. This chondroblast will form a cartilaginous bone. they will form a model of the bone, which is a cartilaginous bone. Okay, like this. Okay, and then the calcification of this bone started. Okay, initially on the time of birth, you have just this cartilage. Okay, and then when the birth happened, okay, when the fetus delivered, then the calcification of this bone started. Okay, and what you will get is the calcified bone. Is that okay?
Yeah.
So first you will have the cartilaginous bone model, okay, and which is made by the chondrocytes, okay, and then the osteoclast cells and the osteoblast cells will come to there, and they will replace this this cartilage this cartilaginous bone with the real bone by the calcification of this bone. Is that okay? They will replace this with the woven bone, and then to the lamellar bone. Is that okay?
Yes.
This is known as the endochondral ossification, and this ossification generally done in the axial skeleton as well as the appendicular skeleton and the base of the skull. Okay, so axial skeleton, appendicular skeleton, and the base of the skulls. That means your hands, you know, your femur, your humerus, your tibia, fibula. All these bones are formed because of the endochondral ossification. Okay, they initially have this kind of a shape, which is a predetermined shape, and then the ossification happens. And the last part to get the ossified is basically a growth plate. Okay, because you know that the growth plate is there. Okay, so what happens at the time of growth? Okay, this cartilaginous cell, they will again form this bone model. They will again form this cartilaginous bone that will have the bone growth, and then the ossification of this bone happens. Okay, and these will become the real bone, right? And once the ossification of this part of this metaphyseal plate is happened, then the growth of the bone will be stopped. Is that okay?
Yeah.
So that's about the endochondral ossification. And this endochondral ossification is kind of defective in case of achondroplasia. Okay, and in that case, you won't be having any growth, any linear growth of the bone, and what you will have is a short stature. Okay, very important. Whenever a fracture happens, okay, first what you will get is the woven bone, which is kind of a very disorganized type of bone. Okay, then this disorganized type of bone is replaced with the lamellar bone. See, you need time to make the lamellar bone, but you know, once you have the fracture, you just need to form the bone somehow. Doesn't mean if it is weaker, okay, but you have to form the bone somehow. So the instant way to form a bone is the woven bone. It is disorganized, but it is a bone, right? Once the woven bone is formed and the structure is kind of stabilized, then you will replace this woven bone with the lamellar bone, okay, which is kind of very much organized and very much stronger than the woven bone, right? But it will take time to form it. So a very instant way to kind of repair the fracture is to form the woven bone first and then replace it with the lamellar bone. Is that okay?
Yeah.
It happens every time you get a fracture, okay, and this thing happens in the Paget's disease. In Paget's disease, you will be having a more formation of the woven bone, and it will not be replacing with the lamellar bone, kind of a defective thing. Then second type is the membranous ossification. Okay, in this type of bone formation, you do not require uh, any kind of this bone model. Okay, no cartilage is required. Okay, suddenly at a time of birth, okay, during the fetal life, the bone formation occur randomly. Okay, and it will form the bone. Okay, there won't be any cartilage present in the sorry before the bone. Okay, there won't be any cartilages present. Okay, it's just a bone form. Okay, just like that. Okay, so it will be the membranous ossification. The bones which are formed by the membranous ossification, they include the calvarium, okay, the facial bones, and the clavicle. These bones are formed by the membranous ossification. Okay, woven form is directly formed without any cartilage, and then this woven bone will be replaced by the lamellar bone. In case of endochondral ossification, you first have the cartilaginous bone. The cartilaginous bone will be replaced by the woven bone and then by the lamellar bone. But in case of membranous ossification, no cartilage was present. Okay, this woven bone will form first and then replaced by the lamellar bone without any cartilage. So in case of achondroplasia, because only the endochondral ossification is affected, you will get the shortening of limbs only, right? While your calvarium, your face, your clavicle will be absolutely normal, right?
Yeah.
Some of the flat bones like the ribs, they are also made up of the membranous ossification. Do remember these facts also. So any doubts so far about the bone formation?
No, thank you.
Okay, now let's discuss the bone structure. Okay. So first we have divided the bone into three parts. Okay. One is the epiphysis, second is the metaphysis, and third is the diaphysis. Okay. The part which is near the head is the epiphysis, and the part which makes your shaft of the bone is known as the diaphysis. The part in between the epiphysis and the diaphysis is the metaphysis, which contains the actual growth plate. Right. Now, if I cut the bone like that, okay, if I cut the bone in the horizontal position, I can see some layers of the bone. Okay, and the outermost layer of the bone is the periosteum. Okay, the periosteum is again of two types. The outermost, which you can see here on this bone, this is a fibrous periosteum. Okay, whenever you look at the bone and this part of the bone which you see from the outside, this is the fibrous periosteum. Just after the fibrous periosteum, you have this stem cell layer, okay, which is the cellular periosteum. This periosteum contains the stem cells of your bone, okay, the osteoblast cells, the osteoclast cells, and the chondroblast cells. Please turn off your mic.
The password, I didn't put the password.
We can't hear.
Okay, now is that okay?
Yeah.
Okay, so we have discussed about the cellular periosteum and the fibrous periosteum. The cellular periosteum contain the all these stem cell layer. Is that okay?
Could you please repeat once?
See, whenever a fracture happens in my bone or whenever I need to remodel my bone, okay, all of the cells which are going to remodel the bone or to repair the fractures, they all will come from the cellular periosteum. Okay, it contains the osteoclast, the osteoblast, and the chondroblast cells, right?
Okay.
So this cellular periosteum, it contains the all these progenitor cells, and the fibrous periosteum is basically a protective layer of my bone. Okay.
Yeah.
So that's about the periosteum. Just give me a second. Yeah. And after the periosteum, you have two parts of the bone. One is the cortical bone, and second is the trabecular bone. Okay. The cortical bone, as you can see here, it is the outer part, and the trabecular bone is the inner part. Both the cortical bone and the trabecular bone, they are made up of the lamellar type of bone that we have discussed. So you have two type of bone formations, right? The woven bone and the lamellar bone, right?
Yes.
And it is a lamellar bone which is ultimately forming your real bone, right? So in both the cortex as well as in the medulla, or you can say the trabecula, right? You have this lamellar bone formation. Okay. What does this lamellar bone formation means? You have this bone arrangement in the form of lamellae. These are the concentric ring-like structures, as you can see, and these are the lamellae. Okay. In between the lamellae, you have some pockets in which these osteocytes are kind of, trapped. While forming the bone, the osteoclast cells will destroy the bone, and the osteoblast cells will form the bone. While forming the bone, some of the osteoblast cells get trapped, right? And now these cells are known as the osteocyte cell. The function of these cells is to regulate the bone is to regulate this bone thing. Okay, whenever a damage happens to my bone or whenever my bone needs to repair, these cells will get activated and they will send signal to the osteoblast cells that we need the bone formation now. And then the bone formation begins. So whenever I got a fracture, whenever I have a high level of this parathyroid hormone, okay, or a high or low level of the calcium, which means whenever I need to resorb my bone or whenever I need to form my bone, okay, these cells will send a signal, the osteocyte cells, okay, very important. They will send a signal to the periosteum and the cells will get stimulated and they will cause the formation of bone or the destruction of the bone. Is that okay?
Yes.
In the center of this lamellae, you're having this Haversian canal system, okay, that consists of this artery, vein, and the nerve, and this is known as the Haversian canal in the center of this lamellae. Okay, so lamellae are the concentric layers in which my bone is actually forming. Finally, right in the center, I'm having this Haversian canal. During the formation, we have discussed we have first is the woven bone formation, which is kind of a very irregular type of bone. Okay, it is a very weak bone. Okay, but it forms very instantly. That's why for a temporary purpose, our body makes the woven bone first. Then this woven bone will be replaced by the lamellar bone, as you can see. Okay, and these lamellars that consist of two parts. One is the organic part and one is the inorganic part. So I can say that my bone actually is formed of two parts. One is the organic part and second is the inorganic part. The organic part is known as the collagen and the inorganic part is known as the hydroxyapatite, which means the calcium phosphate. Calcium phosphate and some other ions also, they form the hydroxyapatite, right?
Yeah.
So whenever I say the ossification, that means I'm depositing the calcium phosphate over the collagen. Okay, note that fact. Whenever I say the ossification of my bone is happening, that means I'm depositing the calcium phosphate over my collagen of the bone, right? That means the hydroxyapatite is being deposited. Okay.
Yes.
So that's about the cortex of the bone. As you can see, all of these are in the form of osteons. You call them the osteons, right? And then comes the trabecular bone, okay, which is made up of the trabeculi. And this trabeculi has a very space in between them. Okay, as you can see, these are trabeculi. And even in the trabeculi, I can find this lamellar bone. Okay, when I cut this trabeculi, I can see the lamellar bone in them. And after the trabeculi, my bone is filled with the bone marrow. Okay, this trabeculi have some spaces, as you can see. If I zoom, you can see some spaces in between this trabeculi, right?
Yeah.
In between these spaces, my bone marrow can easily get filled. Okay, and that makes my bone very spongy. So whenever I say a spongy bone, okay, that means my bone is rich in these trabeculi. Okay,
Yes.
and they help in decreasing the weight of the bone as well as in transmitting the forces, okay, or the stress from my bone. These trabeculars will be very helpful in that. So that's about my diaphysis and any doubt on that?
Could you please repeat what you last said?
See, these are the function of the trabecular bone, which is also a spongy bone, is to first decrease the weight of the bone.
Yeah.
Okay, and second is to transfer all this weight. Okay, whenever I bear a weight over my bone, all of this weight will be transferred to one part to another part of the bone with the help of these trabeculi.
Okay. Okay.
Okay,
For
helping
distribution.
conduction of this force or the stress. Okay,
Okay.
and again, so strength, first function. Second function, make the bone very light. Okay, and third function is to transfer all these forces along the bone. It is done by the spongy bone. Okay, and the cortical bone is also known as the compact bone. It will provide the strength completely. Okay, now if we look at the epiphysis part, then this epiphysis part is made up of mainly the spongy bone or the trabecular bone only. It do not contain any cortical bone, a purely trabecular bone. As you can see, these are the trabeculi. Okay, in between the trabeculi, I have this all these spaces where my bone marrow can be easily filled, right? As you can see, and whenever I cut a trabeculi, I can see the lamellar bone there. Okay, function is to resist the mechanical stress and to make the bone very light. Okay, that's what I see in the epiphysis. Is that okay? And this epiphysis has the growth plate in between the metaphysis and the epiphysis. At the junction of these two parts, I have the epiphyseal growth plate, okay, or you can say the metaphyseal growth plate. Both names are correct, right? And that's where the actual growth of my bone happens, right?
Yeah.
So that's about the anatomy of my bone. Any doubts so far?
No, thank you.
Okay, so at the time of my bone remodeling, first my osteocytes, they detect any crack or any damage in the bone, and then they will activate the osteoclast cells and the osteoblast cells. First, the osteoclast cell will start digesting the hydroxyapatite, okay? And when this crack is now completely gone, then the osteoblast cells will go and and they will form the bone there. Okay, so first the osteoclast, they will eat the bone, and then the blast cells, they will form the bone. Okay, and during this formation, during this remodeling process, first my woven bone is formed, and then my this lamellar bone is formed. Okay, and both the trabecular and the cortical bone, ultimately they're made up of the lamellar bone, right?
Yeah.
So if you know this process is already, then we can discuss, and you will be able to understand in what scenarios you will be having this subperiosteal degeneration, right? And in case of osteoporosis, how you're having a damage of this trabecular bone, not the cortical bone first. How in case of how in case of this chronic kidney disease, you will be having a damage of the cortical bone, which is known as the what disease?
Osteitis fibrosa cystica.
Yes. Okay. In that case, you'll be having a periosteal or the cortical bone for disruption first, right? Very important. So, any doubts so far about this bone structure?
No, thank you.
Okay. So remember about the Haversian canal system. Remember, one more thing. These osteocytes, as you can see here, these osteocytes are connected to each other again with the help of connexons. Okay, these osteocytes will be able to connect to each other. Okay, they will communicate to each other with the help of again the connexons. Okay, do remember this point also. Okay, now comes cell biology of the bone. First is the osteoblast cells that will form your bone. Okay, and they require the alkaline medium in order to form the bone, and it is done by the alkaline phosphate. Okay, and they basically differentiated from the mesenchymal stem cells in the periosteum. We have discussed that. Okay, so whenever you have a high activity of osteoblasts, okay, I can measure the alkaline phosphate levels, right? Whenever I say I'm having a high level of alkaline phosphate, that means high level of this activity of the osteoblast cells are there, right? And I can also measure the propeptides of the type 1 collagen. Remember the type 1 collagen, when it is being formed, you call it the pro-collagen first. Okay, this pro-collagen will be exit from the cell. Okay, it consists of this N-terminal and the C-terminal, right?
Yeah.
And then this N and the C terminals will be cleaved off, and now your collagen could be activated into the real collagen, right?
Yeah.
So I can measure this N-terminal propeptide of the type 1 collagen in order to get an idea of how much this collagen being laid down on my bone, right? So this is a propeptide of type 1 collagen, or you can say the N-terminal propeptide of type 1 collagen. Okay, it is released whenever I need a type 1 collagen from the cell, right? Okay, so whenever you have a high PTH level, okay, in that case, I first have the activation of osteoblast, and then I have the activation of osteoclast. Okay, at a very low level of PTH, we have discussed at a low level of, or you can say, just give me a second. Yeah, in the pulsatile fashion, if I secrete the PTH, okay, then it will stimulate the osteoblast cells and it will form the bone instead of resorbing it. Okay, if the pulsatile secretion of the of this PTH occurs, at a very low concentration, of course, you will get the bone formation, but at a high concentration or at a continuous at the continuous release of this PTH, you will get the activation of osteoclast ultimately. So at low levels, the PTH actually help in forming the bone, and you will measure the alkaline phosphate level in order to measure the activity of this PTH. Okay. To remember this fact also, step 1 can ask you this. At the low levels, PTH will form the bone and I will measure the alkaline phosphate level to get an idea of how much bone is being formed. Then comes the osteoclast cells and they require the acidic media to do that. Okay, and the acidic medium is generated by the this carbonic anhydrase enzyme. Okay, so the carbonic anhydrase enzyme will actually generate this acidic media, right? And yeah, and they will activate the osteoclast cells. Okay, and please note the osteoclast cells are formed by the macrophages or the monocytes. So you can say that these osteoclast cells are the macrophages of my bone. Okay, they have this rank receptor on them. Whenever the rank ligand is available, this rank ligand will bind to the rank receptor and they will activate the osteoclast cells. But whenever the OPG is present in my circulation, then this OPG will bind to the rank ligand, and as a result, this rank ligand can never bind to the rank receptor, and as a result, my osteoclast cells will never be activated. And this is the function of your estrogen. Okay, this is a function of my estrogen. The estrogen will cause the increased release of OPG so that this osteoclast differentiation could be inhibited. Is that okay?
Yeah.
And please note on the histology, these osteoclast cells are seen as a multinucleated giant cells. Okay, they have around 2 to 10 nuclei. Okay, very important to know. They have around 2 to 10 nuclei on the microscopy whenever you look. Okay, and that's why the giant cell tumor is actually a tumor of osteoclast cells. Okay.
Yeah.
Do note this fact also. And whenever I have a high activity of these osteoclast cells, I can measure the level of hydroxyproline. Okay, the collagen telopeptides. Okay, these are the markers of my bone resorption. Okay, I can also measure the activity of my acid phosphatase. Okay, so whenever I get the activation of osteoclast, I can measure the activity of my acid phosphatase. I can measure the this hydroxyproline levels. Okay, and for the PTH, I can measure the cyclic AMP level also, right? And they will give me an idea of the bone resorption, right?
Yeah.
Then you have the parathyroid hormone. We have discussed how this works, and then the estrogen. Again, we have discussed how this estrogen works. It will increase the OPG, and as a result, the OPG will bind to the rank ligand. It won't let the rank ligand bind to the rank receptor, and as a result, my osteoclast cells are inhibited, and osteoblast cells are activated. Now, the other function of the estrogen is to cause the growth at the metaphyseal plate or the epiphyseal plate, right? The estrogen will cause the growth at the epiphyseal plate, but at the same time, while causing the growth, it also causes a closure of the epiphyseal plate. Okay, it is causing the growth, and at the same time, it is also closing it. So whenever at the time of puberty, initially I get the bone growth, overall growth, and then I will get the closure of my bone. Is that okay?
Could you please repeat once?
We have studied that already in the endocrine section, if you guys remember, from the endocrine. We have discussed about the growth hormone, how they can lead to the gigantism, and how this estrogen can lead to the short stature. Remember?
Yes, yes.
The same fact here. Okay, first of all, you're having a growth, and then you're having a closure of these plates, right? So in a patient who's having a precocious puberty or a very high level of this estrogen, they will initially got a very rapid growth, and they will be the tallest person in the class at a very initial time of the puberty. But at the end of the puberty, they will end up being a short stature person. Okay. Yeah.
Yes, yes. Thank you.
So, any doubts so far?
No, thank you.
That was everything about the anatomy and the physiology of the musculoskeletal. Okay. And now let's discuss the pathology. First, you have the overuse injury. Please note the extensor muscles, okay, they originate from the lateral epicondyle, okay, and the flexor muscles of your hand, they originate from the medial epicondyle, okay. So whenever you have a medial epicondyle damage, you will have a loss of flexion, and whenever you have a lateral epicondyle damage, you will have a loss of extension. Is that okay?
Yeah.
So in case of medial epicondylitis, you will be it is because of the repetitive flexion, and you will be having a pain in the medial epicondyle, okay, and the patient will be having a pain whenever they try to flex their hand. In case of lateral epicondylitis, you will be having an inflammation at the lateral epicondyle, and whenever patient try to extend their hands, they will have a pain in the lateral epicondyle. Is that okay?
Yes.
And it is because of the overuse injury. So that's about it. Then you have the metacarpal neck fracture, and it is also known as the boxer's fracture. Whenever you make a direct blow at the wall from the fist, okay, in a closed fist, okay, your the fourth and the fifth metacarpopharyngeal joints, or you can say fourth or the fifth metacarpals, these are the most common bones to be damaged. The little finger and next to little finger, okay, the ring finger mainly. These two fingers, the metacarpals of these fingers will get damaged first because of the punching directly in a wall. It is also known as a boxer's fracture. Is that okay?
Yes.
Then you have the carpal tunnel syndrome, and you know already about the carpal tunnel, which is a tunnel through which my median nerve passes. In the carpal tunnel syndrome, I'm having the impingement or the entrapment of my medial nerve in this canal. Okay, and it is known as a transverse carpal ligament, which forms my carpal tunnel. Okay, and it is also known as a flexor retinaculum. Okay, which is present on the flexor surface. So the name the flexor retinaculum or the transverse carpal ligament, both are same. Okay, they will form my carpal tunnel, and in this tunnel my median will get entrapped and will cause the symptoms. So symptoms, first of all, because of nerve compression, we get the paresthesia, so we will get the pain, you will get the numbness in the distribution of the median nerve in the hand. Okay, the thenar eminence atrophy happens. Okay, but the sensation over the thenar eminence is preserved. Can anyone tell me why?
The nerve to it is given before the flexor retinaculum.
Exactly. Now, for a sensory impulse is already given before the flexor retinaculum, right? And that's why the sensory impulses are absolutely normal. But I will get the atrophy of my thenar eminence because of loss of median nerve, as you can see here, right? Can I also have a loss of senses of my first, second, and the third finger? Sorry, second, third, and fourth finger. Sensory loss. Can I have that?
Mm,
Yeah.
yeah.
Yes. So you will have the sensory loss of the second, third, and the fourth finger, but not the thumb. Okay, because only the sensory supply to the thumb is given off before the flexor retinaculum, right? Rest all the supplies are given after the flexor retinaculum. So a sensory loss as well as a motor loss happened to these fingers, but a motor loss only happened to the thumb or the thenar eminence. Is that okay?
Yes.
And because a distal lesion is there, can I have a loss of lumbricals also?
Yeah.
But I'm having a normal hand muscles, right? That means my flexion of the fingers is absolutely normal, but the function of lacrimals, these lumbricals are lost. And what I can get now because of distal lesion of the median nerve?
Claw fingers.
Exactly, the claw of median nerve I will get, right? So atrophy of thenar eminence, but the sensation is spared. The claw of this, the claw of the median nerve I will get, and the sensory loss over the second, third, and the half of this fourth finger happens, right?
Yes.
These are the symptoms of the carpal tunnel. Okay, then you will get the Tinel sign, in which when you tap on this median nerve, I will get these spasms over my first, second, third, and fourth finger. Okay, and second is a Fallon maneuver, in which I will hold a paper, okay, in between my two hands. Okay, will after making a flexion at the 90-degree, as you can see in this figure also, I will make a flexion at the 90-degree, and I will hold a paper in between my hands, right? And it will cause a tingling. Okay, and that's how I know the patient is having a carpal tunnel syndrome. Now the causes, it is associated with the pregnancy, because in the pregnancy you will be having a high plasma volume, right? And when the plasma volume increase, I can get the edema also, and because of the edema I can get the carpal tunnel syndrome. Second is the rheumatoid arthritis, because of the inflammation you will get that. Okay, third is the hypothyroidism, because of deposition of the glycosaminoglycans. In case of hypothyroidism you can have this syndrome. In case of diabetes, you will be having a connective tissue diseases. You will have the connective tissue thickening because of this non-enzymatic glycosylation. You will be having a deposition of these products that can cause the carpal tunnel syndrome. Acromegaly, because of this increase in the bone size, you can have a compression of the median nerve. In case of dialysis-related amyloidosis, because of deposition of this protein outside the cell, you can have this carpal tunnel syndrome. Okay, and because of the repetitive use, like in case of any typing, you can have the syndrome also. Is that okay?
Yeah.
All the causes, right? And the treatment includes a cut at the transverse ligament. You will make a longitudinal cut, like in this direction, okay, in the transverse ligament, and I can get the relief from this syndrome. Is that okay?
Yeah.
Okay, and yeah, similar to carpal tunnel syndrome, I also have the Guyon's canal syndrome, in which my ulnar nerve can get compressed. Okay, it can happen because of it is mostly seen as cyclists, because of an increase in pressure continuously, and second, it can also happen because of the fracture of which bone?
Scaphoid.
No, scaphoid is more lateral, not medial. The most medial bone.
Pisiform.
Pisiform is very much a small bone. Hamate.
Yeah. Sorry.
The fracture of hamate can cause a Guyon's canal syndrome. See, you don't need to remember the exact name of the bones. If you just remember at the location of the ulnar nerve, which is medial, so you can think about the medial bones only, right? Even if you're forgetting the name, you can just have some idea of what are the medial structures, what are the lateral structures. Then you can get, yeah, this bone is involved for sure. Okay, and that thing will help you making an educated guess in the exam, because in the exam, you don't always remember every information, right? It is not always the case. So at some places you need to make the educated guess. For that, you need to have a basic idea of what things are there, right? So that's why just have an idea of these structures. That will help you very much.
Okay.
Okay.
Yeah. Thank you.
So any doubt on this page?
No, thank you.
Just give me a second. Okay, now comes the cervical fracture, which is very much common in the children. Okay, and the most common location of the cervical fracture is the uh, 2/3 and the 1/3 location. Okay, 2/3 location from the medial and 1/3 from the location. Oh, sorry, 1/3 from the lateral. This is the most common or the weakest point in the clavicle fracture. So weakest point at the junction of the medial and the lateral third, or you can say from the medial. If I draw the bone, this is my bone, right? This is the medial 1/3. Oh, sorry, medial 2/3. Okay, and this is the lateral 1/3, right? So a junction of the medial 2/3 or the lateral 1/3 is the most common location of the clavicle fracture. Or as the FA says, if I divide this bone into three parts, then the junction of the middle 1/3 and the lateral 1/3 is the most common location of the clavicular fracture, right?
Yeah.
Okay, so certain muscles are attached over my clavicles, like the deltoids, like the trapezius muscles, right? And like the sternocleidomastoids. Okay, so whenever the fracture happens, okay, the trapezius muscle, which is kind of more medially attached to the clavicle, and similarly the sternocleidomastoid, which is more medially attached to the clavicle. Okay, as a result, the proximal segment or the segment which is more medial, it will be kind of dislocated upwards. Okay, it will be pulled upwards and medially by the sternocleidomastoids and the trapezius. Similarly, the distal portion or the lateral portion to which my deltoids are attached. Now, because of my arm weight and because of my deltoids, this part will be pulled downwards or it will be dislocated downwards. So as a result, the proximal part will be upward and the distal part will be downward, as you can see. Okay, this is a trapezius muscle pulling my this clavicle upward, and similarly I have the sternocleidomastoid also pulling my this bone upward. I have the deltoids here pulling my bone downward, and similarly the weight of my arm is also pulling the vein this bone downward, right? And that causes the dislocation and a very improper type of fracture healing. This will make the fracture healing very much harder, and even if the fracture are healed, then it will be a very dysmorphic type of bone form, right?
Yeah.
So these patients will be present as a shoulder drop, shortened clavicle, okay, and the medial rotated by the arm abductors. And yeah, the pectoralis, it will be attached on the middle side. Sorry, it is present on the middle side and will attach on the lateral part. So this lateral part will be kind of medially rotated, okay, downward, and the medially rotated you will get. So step one will ask you what structures pulling the bone upward and what structures pulling the bone downward. So please note the deltoid and the weight pulling downward and trapezius and the sternocleidomastoids pulling the bone upward. Okay.
Yeah.
Then you have the unhappy triad, in which whenever a lateral force is applied, and what does this lateral force known as? Valgus or varus?
Valgus.
Yeah. Whenever I applied a lateral force, which means a lateral to medial, okay, which means a valgus force, I can have a damage of my this middle meniscus. Okay, I will be having a damage of my medial collateral ligament as well as a damage of my anterior cruciate ligament, and this is known as the unhappy triad. A damage to the anterior cruciate ligament, the middle collateral ligament, and the middle meniscus. Okay, very important. And but the FA again says a line that means the lateral meniscus involvement is much more common than the medial meniscus involvement in conjunction with the ACL and the MCL injury. Whenever in normal scenarios, if I have the ACL or the MCL injury, then most commonly I could damage my lateral meniscus. But in case of this lateral force, in case of this valgus force, when I having the unhappy triad, in that case, I'm having a damage to my MCL, ACL, and the medial meniscus. While in generally, if I'm not having this type of force impact, in that case, along with the MCL or the ACL injury, I generally have the lateral meniscus tear. Is that okay?
Yeah.
And these patients will of course present with the acute pain, and when you apply these tests for the knee joint, you will have a widening of the space in the middle side of the bone, and you will also have the anterior dislocation of the tibia, right?
Yes.
These are all the signs and symptoms of the unhappy triad. Any doubt?
No, thank you.
Then you know about the bursitis, which is basically the inflammation of your bursa. Okay, in the joints you have the bursa to provide some kind of a cushion. Okay, so there are friction between the muscles and the tendons. Okay, and the bones could be reduced. Okay, but with the overuse sometimes or with other inflammations, I can also get the inflammation of these bursas, and as a result, I will get the bursitis. Okay, so and you and if the bursa is more superficial, then the symptoms are very much pronounced. If the bursas are kind of deep, then the symptoms are very few, or sometimes the conditions are even asymptomatic. Okay, so it is a so let's talk about the prepatellar bursitis, which is an inflammation of my prepatellar bursa. As you can see, this is my femur. Okay, this is my tibia, and this is my kneecap. Okay, and I have this prepatellar bursa here. Okay, and as you can see, the edema is there in the bursa, and the fluid is being filled in this bursa. Right, this is an inflammation of my prepatellar bursa known as the bursitis. It has happened because of the kneeling. Okay, so generally seen in the housemates or the gardener workers who spend most of the time on their knees, right? So the step one will always give you a history of the patient who is who kind of spent very hours on his knees, and now he's having this knee pain. Okay, how the symptoms will be present? The patient will be having a knee pain, acute swelling will be there because of this bursa, because of superficial location of this bursa. If the inflammation and edema is there or the swelling is there, it will be appear on the outside. So a swelling would be there. Okay, a redness of the area would be there, right? History is very important. Then you will get a very localized tenderness in the area of this bursa. At the area where this bursa is present, you will get a tenderness in that area, and it is a very much localized to the bursa only, right? So this is a localized tenderness would be there. Okay, the range of motion, because the joint is absolutely normal, this condition do not affects my joint, and that's why the range of motion is absolutely normal. While the active range of motion, sometimes it is decreased if the inflammation is too much. Okay, if the inflammation is very much increased, which can even involving my joints, in that case my active range of motion sometimes decrease. But most of the time, both the active and the passive range of motions are absolutely normal. Okay.
Yeah.
Then you also have the suprapatellar bursitis, which is just above the patella. I have the bursa here. Okay, this is the suprapatellar bursa. Okay, and the inflammation of this bursa can happen in the athletes because of the cordyceps overuse. Okay, so and apart from that, any direct blow to the distal thigh, which is just above the kneecap, if I have any direct blow, then I can also have the inflammation of this bursa, and this is the suprapatellar bursitis. So I have the redness, swelling just above the kneecap, as well as a localized pain on palpation. Okay, that means a tenderness just above my knee, right? So whenever would describe this kind of a scenario, that means it is a suprapatellar bursitis. Then you have the Baker cyst, okay, which is basically a fluid collection in the popliteal space. It is a popliteal fluid collection. Okay, as you can see here, this, right? This is a space and this is a fluid collection, right? And it happens between the gastrocnemius muscles and the semitendinous muscle bursa. You have the bursa between the gastrocnemius muscles and the semitendinous muscle or a semimembranous muscle, right? And the fluid collection in this bursa is the Baker cyst, and generally seen in the patients with the osteoarthritis or the rheumatoid arthritis. So it will appear as a swelling behind the kneecap. Okay, sometimes a pain could be there, but most of the time pain won't be there. Okay, mostly there would be a swelling, and sometimes a nerve can even get compressed, because the tibial nerve just run in posterior to the tibial bone. Okay, and when the bursa affects there, it can even compress my tibial nerve, and it can cause the symptoms of the nerve compression, right?
Yeah.
So do remember about the Baker cyst, which is a collection of fluid in the bursa, okay, in the popliteal space between the semimembranous muscle and the gastrocnemius muscle. It will be appear as a swelling just behind the kneecap, okay, in the posterior region, and it can also compress the tibial nerve. Sometimes can cause uh, the paralysis of this nerve, right? And the bursitis, they do not interfere with the joint range of motion. It will be absolutely normal because they do not interfere with the joint. They just causes a swelling. Okay, swelling would be there, acute pain would be there, along with the tenderness over the area with the localized tenderness. Okay, and the range of motion will be absolutely normal. Any doubts so far?
No, thank you.
Okay. Okay, then you have some other common musculoskeletal conditions. First is the the tenosynovitis, okay, which is a non-inflammatory condition or the thickening, you can say. Although it has a name itis in it, but it is not the inflammatory condition. It is just the thickening of the abductor pollicis longus tendon happens because of the overuse of this tendon or the overuse of the thumb. Okay, so a thickening of the abductor pollicis longus or the extensor pollicis brevis tendon happens because of the overuse thing. You will have the pain and the tenderness in the radial styloid location, which means the lateral part of your wrist. You will have the pain, okay, and you will have the positive Finkelstein test. Okay, whenever you do the active stretch of the thumb, you will have the pain in the radial styloid or the lateral part of your wrist. So if the Stefan describe a patient who is having a pain on the movement of the thumb on the lateral side of the wrist, That means they're talking about the decovariant tenosynovitis. Okay, and it is because of the overuse of this thumb. Okay, and it is a non-inflammatory condition. Do remember that. Okay, so the thumb and the wrist pain, you will think about the decovariant tenosynovitis. Okay.
Yeah, yeah.
Then you have the ganglionic cyst. See, the ganglionic cyst is basically due to the degeneration, okay, of the articular tissue and the periarticular tissue, right? You have this synovial capsule, okay, which forms the joint, right? Which
Yeah.
covers the joint. Whenever the degeneration of these structures, the tendons, these synovial capsules and other membranes happen, due to the degeneration of these structures, herniation of the connective tissue happens. Okay, and because of the herniation, like say, let me draw. Let's suppose this is my one bone. Okay, this is my second bone. And you have this synovial capsule surrounding that this joint, right? It is a type of synovial joint, let's say. Okay, so whenever the degeneration of this tissue happens, synovial tissue or any other tissue happens, as a result, the herniation of this tissue happens like that. This tissue will be herniated, right?
Yes.
And this herniated tissue will appear as the ganglionic cyst. Okay, and because this space is continuous with the fluid here, okay, so this ganglionic cyst will also contain the fluid.
Yeah.
Right, and that's why the FA mentioned that it is a fluid-filled swelling over the tendon or the joint sheet. It has happened because of the degeneration of the connective tissue, and as a result of degeneration, herniation of the connective tissue happens. Okay, it could be a tendon sheet, it could be a joint capsule, it could be a bursa sometimes. So bursa, joint capsule, tendon sheets, degeneration of these tissues can lead to the herniation of the contents, and as a result, it will appear as the cyst, okay, which is filled with the fluid, and it is known as the ganglionic cyst. Okay.
Yes.
And note some 2-3 facts about this ganglionic cyst. First of all, it will be it will resolve spontaneously without any intervention. Okay, and after some time, the recurrence of this cyst is also very common. So it will go away on its own and it will then come back again. Okay. Most of the times, this ganglionic cyst is completely without pain. Okay, it is always a painless thing. Okay, but sometimes the pain can also happen if this cyst compresses the nerve. You have the subcutaneous nerves, right? And whenever this whenever this ganglionic cyst compresses this subcutaneous nerve, you can even have the pain in that area. Okay. Yeah.
Yeah.
And because this cyst is filled with the fluid, whenever you transluminate it, okay, whenever you you light a torch on it, okay, this structure, this cyst will be transluminate, and that's how you know that this structure is filled with the fluid. Okay, versus in case of lipoma, because lipoma is a kind of solid or solid tumor. Okay, if you flash a light on it, it won't transluminate, right?
Yeah.
So sometimes this cyst can appear as a lipoma also. Okay, but do remember, if they give you this torchlight test, okay, if the structure transluminate, that means it is a cyst. If it do not, that means it is a lipoma. Okay. Then you have the iliotibial band syndrome. Okay. For that, you need to know that the iliotibial band actually attaches on the lateral tibia. Okay. And this gluteus maximus and the tensor fasciae latae, okay, they join to form the iliotibial band. This iliotibial band will run downward, okay, and ultimately it will attach on my lateral tibia, okay, lateral side of the tibia. If I draw a diagram, this is my tibia, right? And on the lateral side, which is this side, I'm having the fibula, right? Yeah,
Yes.
this band will run middle to the laterally and ultimately attaches on this side. Okay, it will attach on the lateral side of my tibia. Okay, very important. Now, it is again an overuse injury, which occurs primarily in the runners because of our overuse of this quadriceps muscle. This tendon, okay, this iliotibial band will run against the lateral femoral epicondyle because of the overuse. Okay, this iliotibial band will run against the lateral epicondyle of the femur, and as a result, I will get the inflammation of this band and I will get the iliotibial band syndrome. I will get a pain at the lateral side of my knee. I will get the pain with the running, with the walking, right on the middle side of my knee, and it is all because of the friction or rubbing of this tendon or this band against my lateral epicondyle of the femur. Is that okay?
Yes.
Then you have the limb compartment syndrome. Okay, and for the limb compartment, first you need to know what compartments exist in our leg. Okay, so you have the anterior compartment, you have the posterior compartment, and you have the lateral compartment. Let me open the file. Just give me a second. Okay, so if I draw the leg, this is my leg. Okay, you have this lateral side, this is the anterior side, this is the medial side, and this is the posterior side. Okay, you have this you have this bones here, right? And you have this anterior compartment. Okay, you have this lateral compartment, and you have this posterior compartment. Okay, three compartments of the leg: anterior, lateral, and the posterior compartment. In the anterior compartment, I have the deep fibular nerve. After division by the common fibular nerve, I have two nerves, which are the superficial and the deep fibular nerve, right? The deep fibular nerve, it runs in the anterior of your leg. Okay, and a superficial fibular nerve, because it causes the eversion and supply the lateral part of your foot. Remember, leg, the lateral part of your leg. Remember,
Yeah.
so it runs in the lateral compartment of your leg. Okay, the superficial fibular nerve, it runs in the lateral compartment, and the deep fibular nerve, it runs in the anterior compartment. Along with the deep fibular nerve, you also have the anterior division of the tibial artery and vein. Okay, you have the tibial artery, which is divided into two divisions. One is the anterior division and second is the posterior division. So the anterior tibial artery and vein, okay, it runs in the anterior this compartment. Okay, and the posterior tibial artery and vein, it runs in the posterior compartment. Similarly, you also have the tibial nerve, which runs in the posterior compartment, right? And you also have the fibular artery and fibular vein, which runs in the posterior compartment. Okay, so for the posterior compartment, you're having a tibia, and along with that, you're having a posterior tibial artery vein. Along with that, you're also having the fibular artery and vein. For the anterior compartment, you're having this you're having this deep fibular nerve. Along with the deep fibular nerve, you're also having this the anterior division or the anterior tibial artery vein. In the lateral part, in the lateral compartment, I'm having this only the superficial fibular nerve. Is that okay?
Yeah.
These are the contents of the compartments. Now, whenever the pressure is increased in any of the compartment, now due to the increase in the pressure, I can get the compression of artery veins. I can get the impingement of the nerve also, right?
Could you please repeat once?
Whenever I get an increase in pressure in these compartments, I can get the compression of my nerve and the compression of artery or the vein in that area.
Yeah.
Okay, and that produces all the symptoms of the compartment syndrome. So the increase in pressure, it could be due to the disruption of the venous outflow, or the arteriolar collapse happens that can lead to the anoxia and the necrosis. Okay, it can happen after the long fractures of the bone. It can happen after the reperfusion injury. Okay, it can happen after the uh, uh, after formation of the venomas. Okay, which is the collateral blood vessel formation. Okay, whenever the venomas are formed, whenever the reperfusion occurs, whenever the fracture happens, I can have the link compartment syndrome. A severe pain would be there. Swelling of the compartment is seen. Okay, and the motor deficits, whenever the motor deficits happens, it signifies a irreversible muscle injury, and the treatment includes a fasciectomy. So they will give you a patient who is having either the anterior compartment syndrome or the posterior compartment syndrome or the lateral compartment syndrome. They will tell you the patient is having a very severe pain or a recent history of any fracture. And they will even tell you the pressure in the anterior, posterior, or the lateral compartment is increased. And then will tell you why the symptoms of this patient is occurring. So this is because of the compression of either the nerve there, either the artery there, or the vein there. Is that okay?
Yeah.
And you just need to remember the corresponding artery, vein, and nerves in every compartment. Then you have this medial tibial stress syndrome. Okay, it generally seen in the runners, in the athletes. Okay, those who play soccer, those who run. Okay, in that case, they will be having a very lower leg pain. Okay, they will be having a lower leg pain. Okay, and also you can say this as a shin pain. Okay, it is also known as shin splints. Okay, it will be a tenderness and the shin pain. Okay, and yeah, it is caused by the bone resorption and the outspaces bone formation in the tibial cortex. Okay, so basically whenever the bone formation is less than the bone resorption, in this case, in case of medial tibial stress syndrome, you will be having a bone resorption more than the bone formation. So ultimately a bone resorption is there. So whenever patient try to run or try to walk after this thing, they will have a pain in the lower tibia or the shin region, right? And this is known as the medial tibial stress syndrome. Okay.
Yes.
Then come the plantar fasciitis. Okay. And it is basically inflammation of the plantar aponeurosis, nothing much. Fasciitis, you guys already know, you will be having an inflammation, you will be having a pain. Okay. Swelling would be there. And you can also have the sepsis sometimes, right? Fasciitis. So any doubt up to this part?
No, thank you.
Okay, so we will take a short break again and then start the childhood musculoskeletal conditions. Okay.
Okay.